That's going.
Okay, perfect. So welcome everyone. We're really excited to be here with you guys tonight. This is a bit of a strange setting for us to do these seminars. We, as a practice, often do a live lecture event 4 times a year. But with all the COVID stuff that is happening at the moment, we're really limited to now just doing this all virtually. In the next slide, we'll talk a bit more about COVID and the impact it's having. But we had some plans for a bit more of an audio-visual kind of spectacle for you guys tonight, but we had to curtail that because of the very recent COVID restrictions that are coming into place in Melbourne, Australia, where we live. So Ben and I are now in separate rooms, not sitting next to each other. And we're just presenting this from our offices. So all the content's going to be on the screen, you know, the singing and dancing and things like that. Probably not as important right now. So we'll get straight into this lecture. So basically about 2 hours worth of content for you guys. We are looking at patellar luxation. I'm giving you about 1 hour on patellar luxation, and Ben is giving you about an hour on portosystemic shunts. So just to introduce Ben, Dr. Ben Kay is he's from Melbourne originally, and then he went over to the UK to do his residency training at the Royal College of Veterinary Surgeons. He's been at the practice now for about 6 months. Really excited to have him here. He's been a great asset to the team. One of the nicest people we have working for us, I believe. Certainly much nicer than me. So if you have any Win Wonderful cases, he loves the Win Wonderful. So feel free to sing out if you have any questions for him. So we'll get stuck into things. I just wanted to make a bit of a note with the COVID situation. Now, this is something that's not going away. Our practice, South Paws, is based in Melbourne, Australia, and just yesterday it was announced that we were having our lockdown measures reinstituted. So we were on stage 3 lockdown, and now we're going back into that because we've had a spike in cases over the last 24 or couple of weeks, really. So pretty frustrating for us in Melbourne. We're getting excited about being able to have more freedoms, and that's all just been kind of taken away. So it's a real thing. It's out there. It's creating a lot of headaches for us as business owners. It's creating a lot of headaches for our team. Everyone is stretched pretty thin and really working themselves to the bone to try and get through all the cases that we've got. And so, you know, it's a real testament to the people that we've got working with us, not only in our hospitals, but we recognise all through the industry, especially in Australia, I'm sure worldwide, people are really bending over backwards to get all the work done. And it seems like a fairly international thing that the caseload is certainly growing and continuing to grow. So I'm just going to mute everyone again as new people come on. I have to keep redoing that. So just a quick snapshot as of an hour or so ago. At the moment in the world, there's almost 12 million cases worldwide. It's been growing fairly consistently and kind of accelerating the last little bit. It's out there. It's not going away. It's causing a lot of challenges and headaches. And really just want to send the message out there. Look, I think everyone just really needs to remember to be kind to each other. If you are in Melbourne or in Australia and you want to talk to me or Charles or anyone here about how things are going, and just check in and see how things are getting on. Especially owning a business, it can be fairly isolating. So if you're having challenges or headaches, just want to put that out there. If you want to talk to us, you're not going out alone. And if we can share our resources and expertise on this, I think that'll only be of benefit. So I want to leave the COVID stuff aside and get onto some more exciting news. And one of the reasons we wanted to have this lecture tonight is to announce something that we are very, very excited about at South Paws. So we are about to open a new hospital. We let this slip in social media and by an email address a week or so ago, but now we are making it much more official. So we are literally about 3 weeks away from opening up the doors of our new hospital, which is in Melbourne, so down the Mornington, down the Mornington Peninsula. So we're really, really happy and excited to get that underway. We basically put this map on here just to give you an idea of where South Paws Moorabbin is. South Paws Moorabbin is up here, much closer to the city, and the new hospital that we've got is down in Mornington here. So we've chosen this location for a number of reasons. We see some cases from down the peninsula. There's a number of hospitals down there refer to us, and we wanted to have a better corridor. We don't have to come through the traffic of the city to access down into Gippsland. So we're going to have a couple of options for people to go now. We're really, expecting to see cases anywhere from kind of Frankston, Plain Warren, out that region, even maybe Cranbourne coming down to us in Mornington, and even out through Gippsland. coming down in through South Gippsland Highway. So we're really excited about it. Close-up view of where the practice actually is located. In Mornington, we've got the Nepean Highway running down here, and then this is Mornington Tyabb Road, and we're just in here on Mornington Tyabb Road. Lots of great coffee shops nearby, a really nice brewery nearby. We've got McDonald's, Hungry Jack's, all the things are important. So certainly well situated, and something we're very proud of and very excited about. So how will the Mornington practice work? Oops. I'm just going to move the attendance screen over. So at the moment, we're opening essentially from Monday to Friday. We still will have Moorabbin Hospital open 7 days a week, and the situation is really that we'll have mostly in the initial stages routine procedures down in Mornington. So we're looking at orthopaedic cases, mass removals, straightforward abdominal explorations and potentially thoracotomies. We are going to have overnight care at the facility when we have patients in-house. And if we have cases that need to stay in over the weekend, then we have options for transport back up to the Moorabbin facility. If there's an emergent case, if the case is in Mornington, coming from the hospitals there or down the peninsula, and there's a bleeding abdomen or something like that needs to be dealt with straight away, then we'd still prefer those cases to come up to Moorabbin. But if you have any interest in referring cases down to Mornington, then please jump on the phone, let us know what it is, and we can organise what is going to work out best. We are actively hiring for this new hospital. We're also actively hiring to deal with the caseload that we've got at Moorabbin. And so in terms of the cases and how they're managed exactly, especially in the first couple of months, there'll just be a little bit of flexibility on exactly how that's going to work. We've got a brand new 64-size CT scan in there. We have the ability with that to do fluoroscopic guided injections and those kind of fancy things. So again, very, very excited about the new technology and toys that we have down there. And expecting to open that facility on about the 27th of July. So it's a builder's 27th of July, so it might get pushed back. We've already delayed things a little bit, but I think that the 27th of July should be realistic. So yeah, very, very excited about that. So a couple of photos, not finished yet. This is in our reception area. The waiting room, it will change. We're putting some new desks and some new timber features inside here. Consult room in the distance here, another consult room just here. New vinyl flooring. And the treatment area, again, we're waiting on all the cabinetry to go in. We've got the CT scanner through this door here. We've got a radiation glass here, so we can have a look and see what's going on inside the room there. We've got 8 runs. If you go through this door just here, there's 8 runs in there. We're going to have some cages in here. And then CT scan in here. So CT room's pretty much finished. Just have to get the air conditioning system commissioned, which is happening this week. And we should be pretty much good to go for the 27th. So very, very excited. Now, the other topic I just wanted to bring up is a new project that Charles and I are working on, and I think that some of you who are logged in watching most likely already aware of this new initiative from Charles and I, which is VetDojo.com. And this is an e-learning platform that we have developed to really try and... We're both really passionate about teaching and educating vets, and particularly with surgery, that's what our area of specialisation is, and really trying to bridge that gap or address the disconnect that we see between what's written in the textbook and what you guys see in real life clinical situations. And so we're trying to distill all that ivory tower information and give you the benefit and insight of our experience, and really come up with great education packages. Some great education packages on various courses, and we really take a deep dive when we look at these different topics into what the different controversies are with these different conditions. We look at the decision-making process that we need to go through, and it's aimed at vets of all ability levels. And when we were putting this together, we collectively came together and said, look, who do we get a lot of questions from, and what do these questions look like? And a lot of the questions that we had, interestingly, came from vets that are experienced vets. So they've been out 8 to 10 years, and they are now in a situation where they found themselves as the lead vet in the practice. And it often created a lot of stress for them, because as the lead vet in the practice, they didn't have junior vets coming to them and asking questions and wanting to know more information about how to perform various procedures. And that was a source of a lot of stress, and they found that it wasn't easy to come across really relevant and clinical information and clinical training that was useful to them in their practice. So that's where we're kind of aiming this stuff. It's really aimed at improving your confidence, and the course material, it's designed to be easy to access. So, I think we've all been to courses and gone in really excited, come away from the course, thinking, all right, we're going to implement all these new things that we've learned and get it going straight away. But then all of a sudden there's a whole bunch of stuff that happens. Then all of a sudden you can't remember where you kept those notes. And so we are really wanting to have it easy to access and broken down into small chunks that are going to be useful for you when you're starting to implement this education. So aiming to improve your confidence with the decision making and ultimately reduce your stress. And if we can reduce your stress, I think you're going to function at a better level. You're going to enjoy the job a lot more. You're going to enjoy what you're doing more. And I think with surgery, it's something that you have to make decisions at the table, and that can be a challenge if you don't feel really well equipped for making those decisions. And so having the understanding of the disease conditions, knowing all the kind of different nuances and the thought processes behind the decisions really helps to reduce that stress. And I think ultimately gives you a lot more enjoyment with what you're doing. If you go to VetDojo.com, we've got basically 4 courses up there at the moment. We've got a lot more in the pipeline. So we have courses on total ear canal ablation. I've recently just put one up on medial patellar luxation. We've got another one on toggle pin, another one on femoral head and neck excision. So it's a starting point. We are willing and we're going to build on that. We've obviously, with the new practice, had a lot of things up in the air and a lot of work to do. So once that all settles down, we're going to get a nose to the grindstone again with the VetDojo content. We're also really excited because we're developing some partnerships with other specialists, both locally and internationally, not only in surgery, but also in other areas of specialisation. And we're also talking to some equine practitioners as well. So we're hoping to get a really robust platform with a lot of content from a lot of different areas and just have something that's really user-friendly and easy to access. And as part of this at the moment, we are giving people that have registered for courses access to our weekly round sessions. And we might build on that content and change some of the pricing around that. But the weekly round sessions are just to kind of catch up with people involved in the course, see how you're going, run through some of the cases that we've seen in the week in the hospital, and then talk through the interesting points with those cases. Also an opportunity, if you guys have cases that you wanted to discuss with us, that you could do that at that time as well. And really, through doing this, we're trying to build and allow access to a like-minded group of vets internationally. And so we're really wanting to reach out to people all over the world and give exposure and education, especially in countries where it may not be easily accessible. We want to have that resource available and access to specialist level intel and ideas that may not be as easy to come by. So that's the idea behind it. If you're interested in VetDojo, certainly jump on to VetDojo.com and have a look around. And if you have any questions, then certainly feel free to reach out to us. So we'll get on to the content, the main content of my lecture tonight, which is on medial patellar luxation. And I put this lecture together because it was an easy one to put together because I've just put together the module on patellar luxation. And I wanted to just show you some of the stuff that's in the module. It kind of scratches the surface. Normally the lectures I've given on medial patellar luxation in the past, normally an hour is plenty of time to go through what we're doing. But I've gone a little bit deeper and looking not so much at just how do you do a tibial crest transposition, looking more at the decision making, the surgical planning and those kind of aspects, looking at the complications and how we deal with some of the challenging things. So we're going to hop straight into that. So where are we going with this talk? We're going to talk about, just need to move the chat box over. We're going to talk about understanding the problem. We're going to look at what the anatomy is. So I'm just moving, I've got to see my slides. Looking at the pathophysiology. We're going to go through the diagnosis, go through a few tips and tricks to help with diagnosis of medial patellar luxation. As I said, we're going to look at some of the decision making, and we're not going to go through every aspect of all the decisions that might come up, but some of the common things, some of the common questions that I get asked. We're going to look at how we create a surgical plan, and I think it's really important to spend time planning every surgery that we do because, the more information we're going to have before we walk in the operating room, the better the outcome we're going to have en masse. And, it's very easy to fall into the trap when we're doing any surgery of getting away with something once and then expecting to be able to get away with that same thing over and over again. But the problem is when you start doing a lot of surgery, seeing a lot of cases, if you start cutting corners consistently, then you're going to start running into problems and eventually you're going to come across a complication that's a real challenge, and it's going to give you a lot of headache. So whenever I'm teaching any surgery or going through any basic kind of training with surgery, I like to think of the one percenters. We use it as a football analogy, and you take care of the one percenters in a game of football, and you're going to go a long way towards winning the game. So looking after as many of these little things as possible along the way with any surgery is going to improve your outcomes across the board. We're going to take a look at the situation where we have combined medial patellar luxation and cranial cruciate ligament disease. That's a very common situation to have to deal with, and there's a bunch of different strategies that we can look at there, and I'll give you my opinions on that. We'll also then go through and look at some of the complications that we see and how we might deal with those complications as well. So again, if you have any questions, feel free to jot them down in the Zoom, in the chat window. Ben's keeping an eye on the chat window there. I've got it up on the screen too, but I'm focused on the lecture. So if you have any questions, feel free to pop them in there, and we'll stop periodically and take those questions. So I'll hop straight into that. So the first thing we're going to think about is the anatomy and pathophysiology. And I'm just going to a bunch of windows here. I'm just going to close this. Okay. So we're going to look at what the problem is. We're going to look at the anatomy and pathophysiology. And in doing that, we're going to look at the surgical anatomy, point out some really important structures that you need to know about if you can do this procedure. And then the number one take home here is that you have to think about alignment of the quadriceps mechanism as being the key to patellar luxation. And that issue with alignment can occur for a bunch of different reasons. And it is really, really important to remember that there's a few different factors that can account for this. And sometimes there's more than one of them at play. So alignment is a problem, alignment of the quadriceps mechanism specifically. And then we have this issue of distal femoral varus. And this can certainly contribute to medial patellar luxation. It contributes in a way that is challenging to know what to do with. And this is it's actually an image that's taken from a CT scan, but it's been made to look essentially like a radiograph. And I put this in here because it really nicely shows the long axis of the femur. And then we can see that the femur starts to bow distally here. We'll look at these images again in a minute. And you can see the effect that has. So at the long axis of the femur, the tibia starts to bone medially, and then we have the attachment point where this red dot is of the patellar tendon. And that's the attachment point of this quadriceps mechanism. And so we can see that with having this distal femoral varus, we have this tibial tuberosity now located in a medial position. Okay, and having it located in a medial position will pull the patella over in a medial direction. And so it's not only that, you might have a straight femur and then the tibial crest is moved to the medial side of the leg. You can have a bowed femur, and that will also result in the tibial tuberosity moving to a more medial location. We'll take a bit more of a look at that in a second. So put this in here just as an initial reminder that, you shouldn't necessarily just assume all the cases are the same, because they have got the and assume that they have a straight leg, and the only problem is that there's medialisation of the tibial crest. That medialisation can occur because you have either got a distal femoral varus, and sometimes even a torsional problem, along with just having a torsional problem in the femur, that is, along with just having the tibial tuberosity located on a more medial aspect of the tibia. So hopefully that all makes sense. So the anatomy that's important, we've got an illustration here of the canine tibia, and some of the bony landmarks that I think are really important. I'm really focusing on the tibial crest transposition with this slide. The really important things to take note of are where the extensor groove is. So this is where it's a useful landmark. It's where the extensor groove runs. It crosses the joint, starts on the femoral condyle laterally, runs down here. It's really important because it's at that level, so everything caudal to that is where the joint articulation actually starts. So everything back here is the joint surface. Everything in front of that point is actually, that's fair game to cut if we want to. So when we're making our osteotomy, we can plan our osteotomy to be anywhere in this region. And we don't want to have the osteotomy situated over here where we create a very small piece of bone. We want to have a nice big osteotomy to enable us to have a robust piece of bone that we can then reattach to the tibia when we perform our tibial crest transposition. And so knowledge of this anatomy, knowing that the extensor groove is there and that we have to be just in front of that, but knowing that that extensor groove is relatively, in the midsection of the tibia, allows us to have confidence that when we actually make our osteotomy, we're not just going to leave ourselves with a very small piece of bone that we have to then reattach. The other thing I just want to point out is that, and we'll look at some pictures of this in a minute, is that the shape of the proximal tibia, the tibial morphology, can vary dramatically between cases. So it's always good when you're doing a surgical plan to have that in mind before you walk in the operating room and understand what the shape of that proximal tibia is going to look like before you get in there. So whenever I do this, I always have the X-rays up on the computer screen so I can see exactly what I'm doing. And I've always got a plan of exactly where this osteotomy is going to go. So I've got a video here. This is one of the videos from VetDojo that we've put together on to some of the 3D anatomy. So there's the introductory section of the video. We'll move into the content in just 1 second. So what we can see here is that long digital extensor tendon. I'll just go back to the section. So that long digital extensor tendon, that's running through the extensor groove. Oops, go back one more time. What was that? And so the long digital extensor tendon is running through that extensor groove. The palpable landmark we can feel is often either the tubercle of Gertie, or just behind that we call it Gertie's cyst, and it's often Gertie's cyst is more prominent bony landmark that we can feel there. But these are important landmarks because, again, we're making our osteotomy in this location just here. So we need to know exactly where they are. So we're then going to look inside the joint. We're going to look at the cranial cruciate ligament. We need to look at the menisci with lateral collateral ligament here attaching onto the fibular head. And these are all structures that we want to identify when we're doing our arthrotomy. We obviously have the patella, as I said, medial lateral meniscus. As we rotate around, we can see the collateral ligament again, this that to the caudal aspect of the joint, and then we can see again medial lateral meniscus, and then we have the caudal cruciate ligament, which we can see just here. We have the meniscofemoral ligament, and then we can see the caudal aspect of the cranial cruciate ligament. And so these videos are available on the VetDojo course, and they're just in small videos, so you can take a look at those and scroll through them at your leisure. And again, they're just highlighting all the important anatomy. On this medial view now, what we're looking at is the medial collateral ligaments. Completely anatomically accurate. The medial collateral ligament comes a bit more down here. But what I'm really wanting to highlight here is where that articular surface is of the tibia. And we're going to be making a cut in the tibia at the more cranial aspect of the So this goes through that rotation and back to the start. So really important structures is when you're getting into the joint. There's videos in the module on the full stifle exploratory, and I think, again, just really easy to use content for you guys to take a look at. So just put a couple of skills out of there just to highlight what we're talking about. So again, looking at that surgical anatomy, and I'm going to hit this point a bunch of times. I really want you to really understand this absolutely before you guys leave this evening. So the extensor groove and the location of the osteotomy is really important. And so we can often take a much bigger piece of that tibial crest than we initially thought. And I think the light bulb moment for a lot of surgeons happened when they started doing the TTA procedure, which is the tibial tuberosity advancement, and they actually realised, you know what, we can take a much bigger piece of that tibial crest than we initially did, because when we do a TTA, we do start to recognise more carefully what the anatomy looks like, and we don't just assume that that joint surface extends a long way cranially. So again, looking at the lateral view there is lateral coligament. Collateral ligament is something you should be able to see in surgery attaching onto the fibular head. When we're doing our exploratory, we're going to be making our incision in the joint capsule at the cranial aspect of the joint, just next to the patellar tendon. When we look at, so I'm just going to mute everyone again. So guys, a few more people jumped on last minute. So 86 people, which is great. When we're looking at the medial aspect, again, we're looking at this articular surface, and this is relatively where our osteotomy location is going to be. So all the important structures are protected. We're protecting the patellar tendon. We're away from that. We're away from where the meniscus is going to be. I think I'll show you an X-ray later on where the osteotomy is made too far caudal and actually does go through the tibial plateau surface, so that's not optimal. We're going to damage the meniscus and going to cause a lot of trauma when we do that. So knowing that anatomy is really, really important. Having an accurate plan in your mind before you walk in the operating room really helps you get that osteotomy correct. So as we talked about, the quadriceps mechanism, malalignment is the key issue that we're trying to deal with. And what structures make up the quadriceps mechanism? A very short video here, but really what we're looking at is the quadriceps muscle, the patella tendon, the tibial tuberosity, and the trochlear groove. And this will all become apparent as we look at this next video. So let's have this short introduction that we've got to go through. And then this will highlight a bit more of the important anatomy as it pertains to the quadriceps mechanism. So tibia fibula, tibia femur, patella, tibial crest, and as we look at that alignment, we can see the tibial crest, the patella, the tropic groove, everything lines up pretty nicely, and we're going to have those muscles attaching onto the rectus femoris. So that's the tropic groove sitting in this location here. Again, this gives you a whip around, shows everything in 3D without any muscles attached. And then in a minute, we're going to come back and add the muscles back on, so we can then see exactly how this alignment will work. So I'm just going to pause this video here. And so if you remember, we rotated this and looked down the length of the femur. So in this dog, it's a normal dog based on a greyhound anatomy. We've got the tibial tuberosity, which is the attachment point of the patellar tendon, and that is in line with the tropic groove, and the patella sitting within the tropic groove, and that is essentially in line with this quadriceps mechanism, or quadriceps muscle. And the quadriceps muscle is actually made up of 4 muscle bellies. But the most important one really is this one here, which is the rectus femoris, and that actually attaches onto this rectus eminence, which is just in front of the femoral head. And so the angle that makes from that rectus femoris makes down onto the patella and relative to the tibial crest dictates the likelihood of there being a medial patellar luxation. So you can imagine that if your attachment point of this quadriceps apparatus is located over here, whether it's because you've got a bone in the femur or whether you've got this tibial crest just located on the medial side, we're all of a sudden going to create a vector when this quadriceps muscle contracts, it's going to pull the patella to the medial side. So I'm going to continue to play this video and it will just show some of the other muscles. So vastus lateralis, rectus femoris, vastus medialis, that rectus femoris muscle again, and then looking forward as we rotate through. And so these 3D animations have come from a program called Easy Anatomy, which is a brilliant program, very inexpensive and a great look at the anatomy in the dog. So again, this is just looking at that alignment issue. And just pulls that there. So we can see this alignment is pretty straight. We can also appreciate that if we move this attachment point over here, then it's going to basically, as that muscle contracts, it's going to want to pull the patella over. So we want to just go on that side. So just highlighted here, this is actually a clinical case now. This is a 3D reconstruction of a dog we treated just recently that has got a medial patellar luxation. And this is just highlighting that vector that's created. So this is actually the right knee in this dog, and this is the left knee, same dog. And we can see that there's 3 red dots all in alignment here. So we've got the patella, the tropic groove, and the tibial tuberosity. And when this quadriceps muscle contracts, there's no tendency for that patella to move medial lateral. The situation over here is now that this attachment point is located medially, and this is for a bunch of reasons. One is that the tibial crest is medial on the tibia, but also this dog had a cruciate rupture, and so you can actually notice that there's some internal rotation of that tibia because of the cruciate rupture, and now this tibial tuberosity is rotated more in a medial location. That's going to contribute to that patella being pulled out. So as that quadriceps contracts, it's going to force that patella out. Okay. So when we're thinking about, again, that medial located tibial tuberosity, we want to think about why that happens. It can happen because of internal rotation of the tibia, like we're seeing in this case with cranial cruciate ligament disease. That's one contributing factor. We can see it, as you remember that first radiograph we looked at with distal femoral virus, and we can also see it potentially with femoral torsion. So when we actually reduce the normal femoral anteversion angle, then we'll effectively externally rotate the femur, and that will potentially create a greater chance of a medial patellar luxation. I'm just going to come back and move everyone again in the lecture. So again, for those guys who are just joining us, if you have any questions, feel free to open up the chat box and just jot them down in the chat room there. If you just address your questions to everyone, then we'll be able to get to those as we come to them. So distal femoral virus, we've talked about this a bit already. This is actually the image we looked at a moment ago, just with our measurements for distal femoral virus. And again, this is highlighting the fact that this distal femoral virus can contribute to the medial location of the tibial tuberosity. So what we're looking at with distal femoral virus is that we have a relatively large anatomic distal femoral lateral angle. So in this case, we've got 109 degrees. And then we can take a normal angle, which is 94 degrees and 95 degrees, so represented here, so the same angle in here. And then we look at our anatomic axis of the femur, and then we create an angle in here, which is 14.2 degrees. So that's the distal femoral varus angle. There's two angles we're looking at. The distal femoral varus angle, which is 14.2, and then we're also looking at the anatomic lateral distal femoral angle, which is 109 degrees. And we can see when we take those lines off, it makes a bit of a busy image to look at, and we straighten up the femur, we can see how wildly displaced that tibial tuberosity is. And then this is actually planned on a program called VPOP Pro. We've actually taken out a 14.3 degree wedge here in planning for distal femoral osteotomy. And in straightening that up, you can see where I've cut it out, we straighten it up, and all of a sudden you can see how straight. So I haven't done anything with this green line, I've just simply rotated, made our cut 14.3 degrees, making a wedge here. And then we close that wedge down, and all of a sudden we can see that the trochlear groove and the patellar tendon and the tibial tuberosity are now all in alignment with the long axis of the femur. So it shows you very clearly how even just a small change, 14.3 degrees, that can result in quite a dramatic change in the distal femur. So moving from the kind of anatomy and understanding what's going on, looking at the diagnosis and tips and tricks. This is something where, in general, the diagnosis is fairly straightforward. You can feel the dog stifle, you can palpate that the patella is luxating in and out, and we know, it's got a patella luxation. But then we have to make some decisions. We have to give a bit more kind of meat to that. So when we're looking at these guys, the first thing I want to do and think about is, what is the grade of the condition? And I'm also going to look for evidence of cruciate disease. We're going to do that through physical examination and radiographs. And it's really important to assess the whole limb. And I put these videos in here as a reminder that before, and there's a whole discussion in the module on VetDojo, but if you are doing an orthopaedic exam, I find the more I've been doing this, the longer I've been practicing, the more information I can get from assessing the dog without actually touching it. Because I think once I start manipulating things and playing with the dog's leg, that's when they start to get unhappy and things can be difficult to interpret. So this is a video on the left of a dog that is walking. This is a dog actually having for a hip replacement today on the left side. He's also got a patella luxation on that side. But we can see as he's walking and the patella's in, he's swaying his hips, but he's able to walk fairly well. And you can see in this video on the right that when his patella's out, he's quite severely affected. So I think it's important to remember and to look at these guys and make an assessment of how bad the condition is and how often is this dog affected by the patella luxation. Because if it's an incidental thing, you've done a vaccination, you're feeling the knees because that's what you always do, and all of a sudden you've found a patella luxation, and it's an 8-year-old dog and it's never had a problem, the owner's never noted it before. What do you do with that dog? Is that the same as what you're going to do for this dog, where when the patella's out, he's really, really lame all the time? And those two things are things that we need to think about and consider as we're working through this treatment plan. And as I say, it's really important to assess this whole limb. And this dog is interesting because he definitely has a patella luxation, grade 2 luxation, but when I felt him, and he's quite severely impacted. So you can see when his patella's in, he's walking pretty well, but he has that hip sway. On the right side, when his patella's out, he's quite badly affected. This dog was actually very, very painful when he palpated his hips. I haven't actually got the imaging in there of his hips, but he had very severe laxity. He's about a 12-month-old dog. And so I spoke to the owners and went through a whole bunch of options for what to do. And this is a common situation as well. We have a dog that presents, and it's not just the textbook, you've got a patella luxation, we need to fix that. This dog also has a bad hip. And we have to start to think about what's the relative contribution of each of those conditions to the problem, and what are we going to correct. And after a long discussion with this owner, my clinical impression was the hip was the most painful problem for this patient. So we would work on the hip first, and then address the patella if and when that needs to be done in the future. And we've done a hip replacement on that dog actually just today, and that all went well. And it's interesting because if we fix the patella first and then we had to come back and do a hip replacement, doing something like that, or if you had to come back and do a femoral head and neck excision, changing the proximal limb and moving all the biomechanics around can actually impact your patella repair. So in general, I'll try and fix the hip first, do whatever we need to do to the hip first, because that's going to set the ultimate position for the femur, and then come back and treat the patella based on that location, rather than treating the patella and then fixing the top of the hip, the top of the leg by fixing the hip and then changing the biomechanics, and then maybe having to come back and do something about the patella again at that point. So it's really important to look at that whole leg and keep in mind, obviously, looking for things like proof of disease with various ways of doing that. So with the diagnosis, again, generally straightforward. We want to grade the condition. A couple of things to point out here. So when we are assessing this leg, I'm just going to play this video through. We want to feel the patella, and in some situations, and to help magnify the luxation, we're going to internally and externally rotate the distal tibia. So I don't think I showed it in this video, but when I actually had this dog's leg in a neutral position, so the foot's kind of sitting straight up towards me, if I just flex and extended that knee, I couldn't get the patella luxate. But if I internally rotated that tibia, as you can see I'm doing there, we can now get that patella to start to move around. And so it's really a useful thing to remember that internal rotation of the tibia will help to magnify if there's a patella luxation there or not. This dog does not have a cruciate rupture. That's the amount of normal internal rotation you can get. And so when we're assessing these guys, it's important to assess them in a neutral position, internally rotate, flex and extend, and see what happens when we're trying to assess firstly what the grade of the condition is and also whether the patella is actually luxating or not. So on radiographs, we want to ensure that we've got nice quality X-rays, and this is all part of the diagnostic workup. And we want to make sure that positioning is good. So these are some really nice straight X-rays of the tibia and the stifle. And we generally want to take 3 views. So I've just shown 2 here, but this is a nice straight AP view and a nice straight lateral stifle view, where we can really only see one condyle. Both of those medial and lateral condyles are superimposed perfectly on each other. And if you look at a nice straight X-ray like this, you can actually see that we've got evidence of effusion in here that's going to be consistent with a cruciate rupture. We've got some osteophytes there. We've got osteophyte on the bottom of the patella. But taking consistent and straight X-rays each time will really, really help you when you're assessing a lot of patients to understand exactly what the challenges are, start to recognise if you do have any angular problems or angular changes. So the views that I like to get as a minimum for patella workup are going to be 3 views. We're going to get a 90-degree lateral view, which is what we've got here, 90 degrees of the stifle, 90 degrees of the top. We're going to get the AP view, which is this one on the left. And we're also going to get an extended lateral. I'll show you that in a second. I've also put in here about getting 2 femur views, and I'll put a question mark here. And these aren't absolutely critical in every case, but I really want you guys to think about it. If you're seeing a lot of patella luxation, then you are going to start to see cases where femoral varus plays a role. And we're not going to go through how to treat the femoral varus in absolute detail tonight, but if femoral varus is playing a role, then you might need to understand that before you start your breast transposition surgery, because the likelihood that you have a successful outcome may change depending on how bad that virus is. So it's worth being aware of it and being understanding it is a factor. And it's not just a factor in big dogs, which we used to think. It can also be seen in little guys as well. So with the femur views, you want to take the lateral and we want to take the cranial caudal, or possibly a caudal cranial, which is actually my preferred view. We're going to talk about that in a second. So what do good quality radiographs look like? So we've got these same X-rays here again. We want to see on the AP view that we've got the fibrillae here, the lateral and medial fibrillae. They're bisected by the cortices of the femur. We want to see the patella sitting within the trochlear groove. And we want to see a nice W shape with a rounded kind of central section when we're looking at the medial lateral condyles. I couldn't make the program make these shapes as nice as I like here, but we want to see that we can see each condyle. We can see the medial aspect of the lateral condyle and the lateral aspect of the medial condyle, and we should be able to see that notch nice and clearly. And we can see that without the green marks over here. We can see the 2 vertical lines of the condyles here and here in that nice condylar notch. Compared to the oblique view where we can't really make out that notch very well. Okay, and on that oblique view, you might be thinking, all right, that dog's got a lateral patella luxation, but it's not actually, it's just that it's not a straight X-ray. When we look at the lateral view, and I see these 2 condyles superimposed on each other, and we want to see the intercondylar eminences sitting like that, normally these 2 little kind of spikes. The other thing on this AP view that I want to point out is that if you've got a truly straight stifle and on hock, then you should see this medial aspect of the calcaneus sitting right over the centre of the talus. So there's a little indentation here. The talus has a little M shape to it, and it's going to be sitting right in the centre there. And so if you are seeing that that's not happening and you've got one part of the leg straight and one part abnormal, and you might have some torsion in the tibia, so be aware of that. But that is what you should be trying to achieve when we're taking nice straight views. When we don't have a straight stifle X-ray, which is a common scenario, then it creates some challenges. Sometimes it's harder to make out a fusion. It's very hard to make out measurements for the tibial plateau angle. I don't believe they're going to be as accurate. And it's harder to get an idea of the shape of the proximal tibial morphology as well. So this is, again, the same dog, just different X-rays. And so we can see that those proximal tibia are quite different shape depending on the level of obliquity we've got. So just got a question that's come through. Any tips for getting nice straight X-rays of the stifles? Points to be looked at while positioning. That's a great question. And I think the most important thing is to have the leg you're going to X-ray on the, right up against the plate. If the hip is sitting off the plate, so if the tibia and the stifle is on the plate, if you've got a large dog and the hip is sitting off the plate, then sometimes it's elevating that greater trochanter about a centimetre or so up off the table, so it's the same height as the plate, can be useful. But when you take this X-ray, if you have the joint flex 90 degrees at the hock, 90 degrees at the stifle, I normally just kind of eyeball it and make sure the tibia is sitting parallel to the plate, take an X-ray at that point and just see what it looks like. And if we've got some rotation, then we need to assess where the condyles are relative to each other to decide, do we need to either lift up the knee or drop the knee, or lift up the greater trochanter or drop the greater trochanter, which is what we need to do here because the condyles are sitting kind of next to each other. If the condyles are sitting, so there's one below the other one, then we would either need to lift the knee or drop the knee relatively. So I just had a comment about the microphone. So I actually don't have a microphone here that I can use, I'm afraid. So just let me know if I need to speak a bit more slowly. We will have a recording of this as well. So if I do need to speak a bit more slowly, just let me know, or yeah, let me know if you have any questions or anything needs just to be clarified with what I've said. So that's the views that we want to take. The first two views, so that's the AP view and then the flex 90-degree lateral hock 90-degree stifle. And then we want to look at the extended stifle view. And the reason this is important, and I like to take this view, is because I want to see in absolute maximal extension of the stifle whereabouts this patella is going to sit relative to the trochlear groove. So in a kind of neutral position, in this dog, the patella is going to sit, within the trochlear groove. But when I actually extend that knee, we can see that the distal aspect of the patella is now sitting much more proximally in that trochlear groove. And in this case, it's not a big issue. But if we look over here, so these are different dogs got open apophyseal growth plates. In this dog, when I fully extend that knee, you can see that the patella is now sitting just above the trochlear groove. And with that, sitting that location, it's possible that because it's not confined by the trochlear groove, it might be a greater chance of luxation. And also there's potential for that patella to actually just catch on the top of the trochlear groove. And I've seen that occur before. That's actually why this dog is being treated. So if we're aware of that situation where we've got what we call patella alta and the patella sitting relatively high, then when we do our tibial crest transposition, we can actually account for that. We can actually move that tibial tuberosity distally and reattach it a bit further distal to actually bring that patella back down into a more normal location. So I really think it's important to take that extended stifle view because it just gives you a bit more intel and a bit more of an idea of exactly what's going on with this case as that dog's leg or as that patella moves through a range of motion. It can also be useful for you to then start to think about, right, well, I'm going to do a trochleoplasty. Whereabouts on the trochlea do I need to do that? Do I need to do it fairly proximal, or do I need to do it in the central section, or do I need to do it further distal? Oftentimes, where we need to do it is up in this proximal location. So I think you need to pay attention to that. So we talked about the femur radiographs before and trying to get a nice straight femur radiograph. And I put this image here because when we're looking at an AP femur, it's quite easy to misinterpret that if it's not straight. And you can make a dog have femoral varus even when it doesn't, if the radiograph's not straight. So we can take this X-ray in two ways. One of them is by extending the hip. So we would just pull the hip back in a normal extended position. The challenge with that is if they have any hip pathology or if they're an older dog,
it's impossible in some cases while the dog's back is flat on the table to get that femur actually parallel to the table. And in order to do that, we might actually need to prop the dog up so his body's sitting up this way and not horizontal, prop the dog up so we can get the hip actually extended further and get that leg parallel to the table. But it's actually much, much easier, like I'm showing in this picture here, to take a caudal to cranial view rather than a cranial to caudal view by pulling the dog's leg alongside the body, and then we essentially have the tibia sticking almost straight up in the air, and we can get a really nice straight AP femur view by doing that. So you can see that it's a bit of a funny view of the distal femur down here. And then we can see that the tibia and the tibial condyles are superimposed over the femur there, because this tibia is sitting more up in a vertical position. But it's a much, much better position, much, much easier to get a really consistent view. And if you're going to look for femoral varus, there's no question that ultimately CT is a better way to assess femoral varus than a radiograph. But if we're going to try and look at it on a radiograph, then we need to make sure that we've got a nice straight view. It's like if you take a banana that has a bow in it and a bend in it, if you look at it from straight on view, it doesn't have any bowing. But if you start to rotate that banana in space, then you can start to see that bow shape to it. It's the same kind of thing because of that procavatum of the femur that we've got. If you start to rotate that femur, then it can start to look really, really misshapen. So we need to get a straight view. And it makes it very inaccurate. Even 5 degrees of inaccuracy with the femur being not parallel to the plate, 5 degrees of inclination or declination will actually give you some changes in the amount of femoral varus that you'll actually measure. So you do need to take care to assess that carefully. So does that radiographic view make sense? I should have put another image in there of the alternate positioning and the challenges we have, but maybe if you guys can just let me know that that makes sense, and then we'll move through the next section. Take this opportunity to have a sip of water.
And James, if you could speak a little bit more loudly, we've just had some people saying that they can't hear very well.
Yeah, so speak a bit more loudly. I'll get the computer closer to me as well. I'll just mute everyone again. Okay. The other thing on the femur radiographs we want to look for is on this lateral view. So we've got a nice straight lateral view of the femur, and we can see that it's a straight lateral view because the femoral condyles are superimposed. In order to assess whether there's any torsion, we want to look at this anteversion, and we can get a rough measurement on the anteversion. We're going to spend a lot of time looking at this, but we want to be able to see that the femoral head is sitting with at least some of the femoral head cranial to the cranial cortex of the femur. And so if we can't see any of that femoral head, so if the femoral head is sitting just within the confines of the remaining femoral bone, and we're looking at it as a lateral view, then we know that we don't have any anteversion. In that situation, that could be a pathologic problem. And it's not a common finding that the torsion is a big factor. It's often going to be the distal femoral varus that's more of a problem. But occasionally we see femoral head and neck fractures where they have a malunion, and that femoral head will actually sit with either 0 degrees of version or potentially, rather than anteversion, we have retroversion and the femoral head sticking out this way. And that can induce quite a dramatic torsional change in the distal tibia, and that can contribute greatly to the medial patellar luxation. So when we've taken our X-rays, we've looked at the dog, we want to grade the patellar luxation, and we generally grade this from 1 to 4. So what grade 1 luxation, I'd really simplify this here. Grade 1 luxation, it's basically in all the time, but we can force it out. It's in all the time, we can force it out. And with those guys, they either have no clinical signs or they're very, very mild. Okay, these are ones we often pick up as an incidental finding. And also with these guys, we're often going to have fairly mild skeletal changes. As we move through a grade 2 luxation, we're going to have the patella in most of the time, but it can spontaneously, and it will spontaneously reduce on its own. So if I have it in all the time, I can luxate it out. But if I move the leg through a range of motion, flex and extend, then the patella will spontaneously reduce on its own. With those guys, the clinical signs are going to be moving, getting a little bit worse in severity. And so we might notice that there's a skipping lameness when they go for a walk, where the patella luxates but then spontaneously reduces. And these guys, again, will often only have fairly mild skeletal changes. So these guys will have often just that medially located tibial tuberosity on the tibia. As we get to the grade 3 or 4 luxations, then we have more severe changes, and we can often have more severe skeletal changes. It can be quite deformed little legs. But the clinical signs, interestingly, when you read the textbooks, it always talks about grade 4 luxations as having these really horrific lamenesses, and they're really, really bad and they can't get around. But in reality, I see a lot of grade 4 luxations where the patella's out all the time. It's probably never been in. And those dogs walk around pretty well. They might have a bit of a bow-legged gait, that cowboy kind of stance, but they actually walk around reasonably well. So just want to, I guess, throw that out there, that it doesn't necessarily bear out that, every situation with a grade 4 luxation, these dogs are completely debilitated. They can, in some situations, walk around okay, and oftentimes they've almost formed another trochlear groove on the medial aspect of the tibia. But with a grade 3 luxation, so grade 1 is in all the time, grade 2 is in most of the time, grade 3 then is out most of the time. It's out most of the time and it wants to stay out on its own, but we can actually force it back in when we palpate the knee. And then the last situation we've got there is a grade 4 luxation where the patella is out all the time and it cannot actually be reduced. And with those changes, again, the clinical signs may be more advanced, but may not be. They still might actually be able to walk around okay, but they will have some abnormalities when we look at them. But the skeletal changes can dramatically vary. And this is what I think is really important to recognise, that when you're dealing with a grade 3 or 4 luxation, a complete assessment of the limb, identifying whether they've got a concurrent cruciate rupture that's contributing to now the fact that patella's, luxated medially, and you've got some tightening up of the medial retinaculum and all those medial soft tissues. And so you need to pay very good attention to what you're doing there to make sure that you're not missing something that could contribute to a change in the decision-making plan. And again, trying to identify if they've got femoral varus, femoral torsion, or another reason for the patella luxation before we start, I think, is always warranted for these high-grade cases. So I want to take a look then at some of the decision-making, looking at some of the commonly encountered problems that we see, and really, I guess, the things to think about, the things that impact my decision-making. I'm going to be thinking about the age and the size of the patient. I'm going to be thinking about the severity of the clinical signs. I'm going to be thinking about whether there's concurrent cranial-cruciate ligament injury, also thinking about whether there's any femoral varus or torsion, and whether the condition is unilateral or bilateral, and how we're going to address those different situations. So why is the age important? Well, in very, very young animals, I'm going to say dogs, 3, 4, 5 months of age, if you diagnose a patella luxation at that age, you should monitor those patients very, very carefully, because as they grow, if the patella luxation goes from being mild in a grade 1, and then all of a sudden it starts to get to a grade 2 or grade 3 as their skeleton's starting to grow, you should really be thinking about trying to intervene earlier to do a soft tissue repair on those cases to try and get the patella in a more normal position, because if we can do that, we can sometimes alter the progression of the skeletal abnormalities and make them less severe. Whereas if we waited and let that patella stay in a medial location and all of a sudden I've got a grade 4 luxation at a young age and then that skeleton keeps growing, what can happen is that those dogs can be induced with a pretty severe femoral varus and a compensatory valgus in the tibia, and those guys can be a real challenge to try and put back together. You can also have challenges in those guys where they develop and the patella's never been in the trochlear groove, that the trochlea doesn't develop completely or doesn't develop at all, and we might need to think about doing something really aggressive like a prosthetic patella groove or something like that to try and reconstruct that area. And so they can be very, very difficult cases to manage. And getting onto it early and addressing them with soft tissue repairs early on, I think is very, very important. Recognizing that even if we do that soft tissue repair, which is a medial release and a lateral imbrication, in most cases, we may still have to come back and do a definitive realignment surgery where we cut some bone once they get older. And I'd say it's about 50% of cases we have to come back and do something. The other situation where I think it's important to recognise age can be a factor is in these dogs that are somewhere around about 10 to 18 months of age. And in these guys, they will have, especially in large breeds, an open tibial apophyseal growth plate like we can see in this situation here. And I think this is important to recognise, because if we tried to do a tibial crest transposition in this dog, we'd be making our osteotomy down here. And then we'd be putting our pins through this location here. And we're putting it right through this very weak section of bone. And I've definitely seen dogs that have been operated this time and had pins go through this section, and they will actually get a tibial crest fracture, and then we'll have to go back and repair that. So my advice to you is to try and wait, if you can, until this growth plate is completely closed before we do the surgery, especially if we're going to do a tibial crest transposition, because it really will help to minimise the risk of a post-operative fracture. And then in adult dogs, obviously we want to ensure that that is completely closed up. So different ways that the age can impact the decision-making there. The other thing with decision-making is the size of the patient, and I generally think of dogs like less than 10 to 15 kilos and dogs greater than 10 to 15 kilos. And that can become a factor because in smaller dogs, I might think about doing the procedure without necessarily using a tension band wire. But in larger dogs, I definitely will be wanting to use a tension band wire to augment the repair that we do with our tibial crest transposition and just putting a couple of pins in there. So that's a little bit about the decision-making with age and the size. Severity clinical signs. As we talked about a little bit about this already, so some cases are easy. It's an easy decision pathway to go down. You've got a young dog, 1 year old, and it's frequently affected by this condition. So every time it goes for a walk, it skips for a few steps, and it happens all the time. It happens every day. It happens every time the dog walks. The owners are concerned about it. And that is a pretty easy situation. And that compares to an older dog with infrequent clinical signs, or sometimes it's an incidental finding, and the patient is in an older situation, is an older dog. And so I think those situations are two different clinical pictures, and they're two clinical pictures that you probably come across all the time, but the decision-making is not necessarily the same for those. In a young dog, it's easy, we should do the surgery. In this older dog, where it's asymptomatic most of the time, then I think you need to think about what are we trying to do with the surgery. And really, the way I think about this, what are we trying to do with the surgery for patellar luxation? Number one, I think the most important thing is to slow down the risk of development of arthritis. The second thing is to improve the clinical signs. And so if the dog doesn't have clinical signs, what are we fixing? And the third thing is to reduce the risk of chronic cruciate ligament disease. And so I had this discussion with every owner that has a dog with patellar luxation because I like them to get involved with the decision-making process and understand, the limitations of what we can and can't do and what we're actually trying to achieve. It's important to set their expectations accurately about what we can and can't do. And so for the dog where it's infrequent clinical signs and it's an older dog, I think you really have to weigh up what are the risks and what are the benefits. And in my opinion, if it's a grade 2 luxation or above, even if it's infrequent clinical signs, I still think there's benefit to doing surgery. And I say that because it's common for these guys to get an ulceration or a loss of cartilage on the articular surface of the patella, and that loss of cartilage will be full thickness. It can be very, very painful. And so I think even if we can get the patella in a more normal position and stop it riding over that trochlear groove, we can first either stop that from happening, or we can certainly make it more comfortable potentially by moving into a more normal location. Still going to be uncomfortable, but generally will make them more comfortable having it riding within the trochlear groove. So a few things to think about. And again, this stuff is, I'm going over a lot of detail, a lot of content in a small amount of time, and there's more detail to all this in the module that we have on VetDojo and patellar luxation. So I want to spend a bit of time looking at this section here, which is dealing with the concurrent cranial cruciate ligament disease and medial patellar luxation at the same time. And how does this impact the decision making? I'm not sure. I'm not going into detail a little bit further into the lecture. When we're looking at these guys, I think it's important to look at the character of the gait. And sometimes, again, if you're looking at the age of presentation, if you have a dog that's 4 or 5 years of age and it presents to you for the first time with a back leg lameness, and then you feel the leg and you notice that it's got a patellar luxation, I would encourage you to really think carefully about, is the patellar luxation in this particular patient the cause of the problem, or is it possible that there's something else going on as well? And oftentimes in these older dogs, so they're 4 or 5 years of age, never shown signs of the typical hopping, skipping lameness, and all of a sudden they've got a lameness more characteristic of a cruciate rupture. So they're slow to get up, they warm up with exercise and they get better. They're worse when they've had a period of rest and they first try and get up after that. Looking at those two differences in the character of the lameness, that arthritic type lameness versus the hopping and skipping type of lameness that we see with patellar luxation, can give some clues as to what might be actually the most important underlying factor for this dog. And so the character of the gait can be one thing to look at. A radiographic assessment can also be very useful. So in my experience, dogs with cruciate rupture will generally have a lot more effusion in their stifle compared with dogs with just a patellar luxation on its own. Not absolute, but that's a fairly good rule of thumb. And the other thing to bear in mind is that when we have a concurrent cranial cruciate ligament rupture, like we can see in this CT image again here, it's a complete rupture in this dog, and so that tibia is now wanting to rotate internally and that internal rotation will magnify any issues that we have with the medial located tibial tuberosity. And again, the treatment options are going to be altered potentially quite dramatically if we have that combination of diseases going on, and we'll talk more about that in just a moment. So again, just whetting your appetite a little bit with the combination of those two conditions at the same time and the factors that we need to think about. Distal femoral varus and torsion, again, how does that affect the decision making? We've looked at these images already, just to flesh this out a bit more. Which cases should be assessed for femoral varus and femoral torsion? And in my opinion, if a case is coming to see me, I want to do as much as I can to ensure a good outcome. So I talk to owners about this for every case. Some owners go for it, some owners don't want to go for it. And I think that it's definitely worthwhile trying to understand, or at least talk to the owners about the implications of distal femoral varus and what that might mean. And so I will generally want to assess every large breed dog. But in a small breed dog, if it's a Pomeranian and the owner says, look, we don't want to spend the money on the CT scan, we want to save the money, we want to do the Xrays, then I think that's okay. I do talk to them and say, look, we're going to do a tibial crest transposition, but if we have reluxation, and that occurs honestly in about 10 to 15% of cases, if we have reluxation, then we need to think very carefully about why that's happened. Is it because we haven't moved the tibial crest far enough on the tibia, or is it because we've got femoral varus and that's a contributing issue? And I think oftentimes when I look at those carefully, it's because we have got femoral varus as a contributing problem. So there's a question here about the techniques we're doing for patellar luxation and cruciate disease at the same time. And I'm going to come back and talk to you guys about that in a few minutes. So if you can hold on, we'll get to that in just a second. Great question. So is the femoral varus treated in every case? And that's another interesting question. So there's no absolute cutoffs for, what is the femoral varus angle that we need to treat, and, what is the anatomic lateral femoral, distal femoral angle that we need to treat. And generally, if I'm getting above 110 degrees with the anatomic lateral distal femoral angle, or if I'm getting a distal femoral varus angle that's greater than 7 to 9, degrees, then I'm going to think about treating it. But it depends on the assessment of the whole leg, and it depends on the conversation I've had with the owners about, the likelihood of success with just a tibial crest transposition and a trochleoplasty, and all those things do weigh into those decisions. What is the best way to assess the femoral varus? We've talked about radiographs. I'm talking about taking straight radiographs, and honestly, the best way to do it is with a CT scan, but I'm very acutely aware that not everyone has a CT scan in their practice that they can use. And so if you don't have a CT scan, then taking X-rays is not a bad substitute, but you do need to make sure those X-rays are of good quality. And generally that caudal to cranial view is going to be the most important one we want to look at. So now I'll put a red line on my screen. I don't know how to get that off. So I do apologise about that. So next thing I want to talk about unilateral or bilateral disease. And when we look at these guys, if we have bilateral disease, unilateral disease, it's intuitive. We do the leg that's affected. When it's bilateral disease, we need to think about, are we going to do a single session bilateral repair, or are we going to do a staged unilateral procedure? And I think that there's pros and cons to both approaches. And in a nutshell, most of the times when I go through the pros and cons with the owners, most people decide that they think that doing a bilateral procedure is their preference, because they can reduce the amount of aftercare. They can take the 8-week restriction, they can make it down to 8 weeks times 2, so 8 weeks for each leg, so 16 weeks overall. They can reduce that down to 12 weeks, because I would normally stage these. So we can get myself confused. We can take the restriction period, which is normally 8 weeks, and I would normally stage them by 4 weeks. So we can take a 12-week period of restriction, or 16 weeks, depending on how long we wait between the procedures. And we can reduce that down to 8 weeks, because we can condense all of that down into just a single time period. There's also a cost implication, so that's going to be a little bit cheaper to do both sides at the same time. I think the risks is an interesting one. There's a couple of studies showing that there's not a definitive increase in the risk profile when we do bilateral procedures compared to unilateral, but in my experience, I think you need to be cautious of doing both at the same time. And patellar luxation, it's an interesting condition, because even amongst specialists, most specialists agree that people really underestimate this disease. If you do a lot of these, you're going to have some challenges with it. And I don't know of anyone that does a lot of surgery that hasn't got a nightmare patellar luxation case in their repertoire somewhere. I certainly do, and you learn your lessons from those things, but it's something that if you do enough of these and do them all the time, then at some point you're going to run into some challenges. And so with the risk doing bilateral single session, I think we need to be really vigilant with the aftercare. And if you've got a really crazy staffy and the owners can't really look after it, can't control it, then I would be very cautious about wanting to do a bilateral repair on that particular patient. The other factor to think about is the number and the length of anaesthetic episodes, and that can be an issue for some people. So again, lots of things to consider and factor in there, and not one absolutely right or wrong way to go. It's a discussion that I think is important to have with the owners and have them on board with what we're doing. So surgical planning, I put in here a quote that I like. I'm not sure who said this, but definitely more mistakes are made by not looking than not knowing. And I think that it's really true of planning surgeries. I think more mistakes are made by not carefully thinking about what we're doing before we get in the operating room. So when making the plan, we have to think about what's causing the malalignment. We need to think about whether that's a medial located tibial tuberosity, have we got femoral varus or torsion, and we need to think about that location of the patella relative to the trochlear groove. And I think that if we assess it on that extended stifle view, we can really get a good impression of that. And again, I'll just put in a comment here to think about that proximal tibial morphology, and we'll look at those in just a second. So when we determine the cause of the problem, I pulled these stills from the video we were looking at before, and this is just to talk about what these lines mean. This is that dog's leg in a neutral position. So the foot is basically coming straight up towards me here. In a neutral position, we could see that the long axis of the femur is represented by this red line. The trochlear groove is represented by these green lines, and the patella is within the trochlear groove. But if we follow that line of the femur down and the patellar tendon where it should go, we can see that tibial tuberosity is located medially. So when I move this leg through a range of motion, I put some gentle pressure on this lateral side of the patella, I can force it medially because we've got the tibial tuberosity located on the medial aspect of the tibia. When we internally rotate that foot or that tibia, we can exacerbate the problem. So now we can see that we've internally rotated, we've moved the tibial tuberosity further over, and now we've actually luxated that patella. But in terms of the planning and what I'm doing here, I want to have the leg in a neutral position, and I'm trying to assess this alignment. If that alignment is pretty good, then I have to start thinking about, well, what is there another cause of the patella luxation other than just this medially located tibial crest? What do we need to actually try and correct there? With a radiographic assessment, that red line is really frustrating. I don't know how to get rid of that. Anyway, we'll keep going. Again, with the radiographic assessment, looking at this extended view, looking to see where does that patella interact with that trochlear groove? Does it sit well within it when it's extended, or does it sit just above it? Okay. When we look at this X-ray here, I think we'll all agree that there's a large amount of effusion in the stifle joint here, and we've also got some arthritis with osteophytes developing on the trochlear ridges. We can see some osteophytes down here and on the distal patella just here as well. So we would also want to look at this tibial apophysis. Is that open or not? This dog we actually postponed until this dog had complete healing of that tibial apophysis before we went in and did surgery on this particular case. And then when I'm making my plan for the tibial osteotomy, I actually will go into this, there's all kinds of programs. The one I use is VPOP Pro, and we will make a plan. I want to measure the length of the osteotomy, so here we've got 22.8 millimeters. And I also want to measure, based off a palpable landmark, so the tibial tuberosity is obviously very clearly identifiable in pretty much every case, how far back from that tibial crest is the osteotomy going to be? So I've measured here 6 millimeters, 5.9 millimeters. So I'm going to get a ruler out in surgery. I'm going to measure from the tibial crest 6 millimeters back, and then I'm going to measure a line from the distal aspect of the tibial crest, which in this dog is fairly indistinct. Some dogs will be much more prominent. Again, that morphology can be very different. And so we're going to measure that line in surgery as being 22.8 millimeters or thereabouts. If I can do that, we end up triangulating fairly well to get an osteotomy plan for where we want it to be. So when we take our post-operative X-rays, we don't have any nasty surprises. Like, geez, that tibial crest is really, really small. I'm worried about how that's going to hold up to the forces it's under. The other thing with the planning is just to, okay, I'm glad Jamshid's here. Get rid of that annotations, controls, chopped annotations, eraser. Jamshid, you're a legend. Thank you very much, mate. So I'm a bit of a Zoom novice here, obviously. So when we make our osteotomy and our plan, we want to be able to take that plan from the X-rays. We want to take it into the operating room and execute that once we get in there. So the other thing to bear in mind, so we're just looking at a single lateral view. The other thing that's important when we're planning this out and thinking about it conceptually is the orientation of this osteotomy. And we want this to be in the frontal plane. So the frontal plane is represented by this black line here. We don't want it to be oblique. So in this orange line or this green line, we want it to be in that frontal plane or perpendicular to the sagittal plane, which is this way. And if we can do that and have it nice and straight, then it'll allow us to actually shift that tibial tuberosity over quite nicely and not create any unintended movements with that. Okay. Again, I've been talking about this tibial morphology, and just to give you some examples of different shaped tibias, I actually had a crack at, when you look at a Dachshund tibia, that's a really nice example of a very altered or different tibial morphology, but just some things to think about. So in these dogs here, we've got different shaped tibial crest, different shaped tibial tuberosities, and in some of these dogs, like this dog, we've got a relatively low insertion point. This dog, we've got a relatively high insertion point of the patellar tendon, and in this dog here, we've got, again, a fairly low insertion point. The distal aspect of that tibial crest is quite different and different in how prominent it is. You wouldn't want to go into this joint and start palpating down here and thinking that that is your proximal tibial crest. You want to be able to feel these things and understand for that individual patient exactly what's going on. So when you get into surgery, there's not going to be any surprises that you need to worry about. So with the surgical planning, we don't only want to think about the osteotomy we're going to think about the pin length and the trajectory of the pins. And when we look at the pin length, I like to measure off the X-ray to see, how long do we think those pins are going to be, 24 millimeters. So if I put those pins in, they're coming out at 30 millimeters. I know that I'm going to be sticking way out into the soft tissues at the back here. And the other thing is to think about the pin trajectory. And so the pin trajectory, when we look at that and we've made our osteotomy on the frontal plane and we've translated that tibial crest over, we want to follow this trajectory of this black line here. We want to direct this pin from a lateral location to a medial location to ensure we're engaging really nice quality bone. We don't want to just drive that pin straight across because we're going to hit some air before we hit the bone, and it's not going to provide as stable a construct as if we actually able to drive that pin in a more lateral to medial direction. The other thing that's really important, and we'll talk about this again in the next slide, is that angle of insertion relative to the anatomic axis of the tibia on this lateral view. And we're really wanting to try and get about a 90-degree angle where this angle A is. If we have an angle that is actually less than 90 degrees, so if you have the pin directed in this direction, then there's a greater chance that that pin will actually pull out and we'll get luxation or avulsion of the tibial crest, compared to if that pin is 90 degrees or potentially even more than 90 degrees. And there's a nice study done by a surgeon that happens to work with us, Ricky Cashmore. And so with his study looking at risk assessment with patellar luxation, 124 dogs, 173 stifles, and actually they noted that there was avulsion in 5 of the cases. And avulsion was more common when a single KY was used. And when a single KY was used, they were 11 times more likely to avulse. No avulsions happened incidentally when there was a tension band used. And no dogs with an insertion angle between 83 and 111 degrees avulse. So if we have the pin trajectory in this kind of blue triangle here, so kind of in this direction, then we won't have any risk of avulsion. But if we have them in this direction, so somewhere between 55 to 83 degrees, then there's a greater chance of that pin actually avulsing because it doesn't counteract the forces applied by the patellar tendon as well. So thinking about that pin trajectory is important. Again, this is little bits of detail, little 1%ers, and if you take care of as many of these 1%ers as possible, then you're going to have a better outcome across the board. And again, all this stuff is in our module on VetDojo. It goes into all this detail. This is really just kind of scratching the surface. So I am conscious that I'm pushing out the time a little bit, but we'll just kind of plug away for a little bit longer, probably give another 5-10 minutes. And we'll throw over to Ben. So looking then, so how do we do the TCT and the trochleoplasty? I wasn't going to include much on this, but very quickly, as I said in one slide, when we do the arthrotomy, so we're going to assess the cranial-cruciate ligament, we want to assess the patellar cartilage, we want to flip that patella over and have a look, see how much damage there is. We're going to do our tibial crest transposition. We're going to plan it carefully. We want a big piece of bone. I think we've hit that pretty importantly. I'm always going to recommend using 2 pins. Okay, using 1 pin does not make sense to me at all. If you have 1 pin, there can be rotation, there can be movement. My recommendation always is to use 2 pins. And I'm plus or minus a tension band. So if it's a smaller dog and I've got good soft tissue attachments, then I'm generally not going to use a tension band. But if it's a big dog, greater than 15 kilos, if it's a nutcase of a dog, it's going to bounce around all over the place, I'm going to use a tension band. Or if I'm doing a distalization as well, and I've destroyed all those soft tissue attachments, then that dog's also going to get a tension band. When we do the trochleoplasty, again, we've talked about this. We want to assess the patella location within the trochleus. So we want to assess in a proximal to distal orientation where that trochleoplasty is actually going to go. Maybe 2 slides. So when we're doing the TCT and trochleoplasty, really nice tip for you guys is when we're trying to assess how far we've translated that tibial crest. I've got a towel clamp on the tibial crest. I'm moving it laterally here. Rather than putting a pin through the tibial crest and then assessing how things look, we can put a pin just next to the tibial crest into this cut surface of the tibia, and that will keep the tibial crest translated and won't put any excessive holes through the tibial crest, and that'll allow you to move the leg through a range of motion and actually assess and make sure that the patella is staying where it needs to go. Again, I didn't want to focus this lecture a lot on the technical aspects of the surgery. A lot of that stuff is elsewhere, and also the VetDojo module. I wanted to focus more on the kind of perioperative management aspects of this problem. And so one more slide. I put this slide in here just to kind of highlight a couple of things. So in this particular dog, this is a dog that actually those growth plates finally closed. The patella was sitting up really proximally here. We've done a distalization. We can see how far distal we've moved that tibial crest. We can see that patella sitting in a much better location. If I'm uber critical of my own X-rays, these pins are a little bit long here. You can see that I have used 2 pins, and I have used a cerclage wire. And it's really important to use appropriate size cerclage wire. You want to go big with this stuff because the pins are actually less important for stability than the cerclage wire. The cerclage wire is the thing that's really counteracting the force of the patella tendon, which is pulling up in this direction. So with the cerclage wire, I always go 2 twists. And we want to make sure when we actually drive that pin through the tibia that we're actually not going through the cortex cranially. So that's got quite a thick cortex in this dog. So I've gone just behind that cortex, and that's where my pin is going through. Sorry, tension band wire is going through. So 3 slides, that's the whole procedure, very easy. There's a lot more to it than that. I just wanted to touch on the kind of really key points there because I only have an hour tonight. So I'm going to probably finish off here. I'm not going to get to the complication section. I do want to hand over to Ben, but we're going to talk about combined medial patellar luxation and cranial-cruciate ligament disease and the fact that this is a very common situation. And again, a variety of presentations for this. These guys can present a number of ways. So they can present with a clinical patellar lameness. So I'm going to say that they've got a hopping and skipping lameness, and then that develops into a cruciate rupture, and then the lameness becomes more of a consistent feature. It's no longer that hopping, skipping lameness where it's there and then it's not there. It's not now a lameness that's there all the time, okay? And they're wanting to hold the leg up more and more commonly. So that's one presentation. Second presentation we see is the cases where the patella is what I sort of call asymptomatic. So you've never noticed, the owners have never noticed this dog being lame. And this is that 4-year-old dog presents for the first time and you feel the knee and you think, yeah, it's got a patella luxation. But then you talk to the owners and say, when did the first clinical signs appear? And they say, look, just only a couple of weeks ago, after the dog was running around in the park. And you think, interesting that it's 4 years old and never had a problem with its patella because its patella has been there forever. And so that makes me think, maybe the cruciate ligament is a factor into what's actually going on here. And then the third situation is that there's no patella luxation initially, but then they rupture the cruciate and we get that internal rotation of the tibia. And now all of a sudden that's enough to create a medial patella luxation. So they're the kind of 3 presentations that I think of when we deal with the combination of these 2 problems. So how do we deal with this? What's the decision making? There's a lot to consider here. So what's the primary issue, do we think? Is it the patella luxation or is it the cranial cruciate ligament? Are we dealing with a small dog, like a Pomeranian, or are we dealing with a larger dog? And I put this dog in here because he was an interesting case of mine from about a year ago now. And then, what are the options for repair? And so the way that I would treat a combination of a cruciate rupture and patellar in this dog here on the left and this dog here on the right are not necessarily going to be the same. This dog here on the right is a unique situation because he's a pelvic limb amputee. Okay, he lost his leg. This was a rescue dog. He lost his leg at a young age from a trauma, and so he's a potentially big challenge. He had a grade 3 MPL, and he had a complete cruciate rupture. And we'll talk about how he actually fixed his leg in a minute. So as we go through this, if we're dealing with a smaller dog, then I think you can look at the option of an extracapsular repair, with a tibial crest transposition plus or minus a trochleoplasty. And for smaller dogs, I think less than 10 kilos. Now, this is, I'll be honest with you, I used to do this all the time for little guys, but now I'm going to do a modified TPLO to treat these as my preference. And so just to talk through the options here, because I understand that most people in general practice aren't going to be doing TPLOs. If you are, then great. We can complicate that further by combining it with options for managing the patella as well. But if you're not doing that, then an option is to do an extracapsular repair and the tibial crest transposition. But I still think there are some important things we need to think about. Now, the situation in this dog is going to be, we want to think of when we're looking at fixing the suture, fixing the cruciate with the extracapsular suture, we want to think very carefully about where those isometric suture locations are. We're not going to talk much about the femoral location. We want to go behind the femur or through a bone tunnel here, a bone anchor. Where we put that location of the tunnel in the proximal tibia is really, really important. And in these particular situations, the isometric point is right at that extensor groove. Now, I often go either just behind that on Gertie's sister or just in front of that, often most commonly just in front of that on the Gertie's tubercle, because I find it an easier landmark to find. And so as long as my osteotomy for my tibial crest transposition is in front of that, I still have real estate here in the proximal tibia to be able to put my my extracapsular suture. And so then when we combine that, the location of tibial osteotomy in here, we can see that we've still got room here. But in a lot of cases, one of the most common problems I see when people do extracapsular repairs is that tibial bone tunnel is nowhere near an appropriate location. So oftentimes it's well too distal or well too cranial. And if you put them in those cranial or distal locations, then you can really run into problems with that suture not being an isometric point. And I certainly don't have time to go into a big discussion about the implications of improper isometry with extracapsular sutures. Suffice to say that if you do get them in the wrong spot, then you're going to ask too much of that suture and it's going to fail prematurely. But if you think about carefully where those attachment points of the suture are going to go, think about carefully where your osteotomy is going to go, then you can effectively achieve both in the same procedure. Okay. So I've just got a question here from Franz Venter. I do get cases where the joint fluid leaks after grade 3 to 4 patella luxations with a medial release. What do you do to close the capsular defect? Do you close the capsule again? And that's a great question. So with the high-grade luxations, we may have to do a medial release, so the medial retinacular release and medial joint capsule release. And the challenge is there, Franz, I don't think in most situations you can adequately close that stuff, certainly not enough to make it watertight and stop the fluid leaking out. And in most of those cases, I'll end up just doing a 2-layer closure with the subcutaneous tissues in the skin. And I don't see a lot of those guys leaking very commonly. So I think if you pay very careful attention to having a couple of layers of closure, then you can do okay. But if you do try and close the joint capsule or close the retinacular tissues, then you often find you're putting more pressure on that medial side of the joint and you're going to cause that imbalance to be a problem again. So I hope that answers the question there for you, friends. So the next option for repair then in a small dog is to do a procedure called a modified TPLO. And what we're going to do here with this modification is actually to medialize the proximal segment. So we've made our normal TPLO cut, and then I've actually taken this plate, which is a fixin plate, and we've made a bend in this one. So this is that 3-legged dog we were looking at before. So I actually did this in a larger breed dog in this case. And so I've made this bend here. I've got about a centimetre gap here. So I've actually moved the proximal part of the tibia medially, moved the proximal part of the tibia medially about a centimetre. And in effect, I've pushed the distal part of the tibia laterally about a centimetre. And in doing that, I've managed to align the tibial crest with the trochlear groove. And you can see the patella sitting in there nicely. And that worked beautifully for this dog. I went for this approach in this dog because he only had 3 legs. He only had 1 back leg, so a lot of pressure on the repair. The other option is to do a modification of the TPLO where we do a tibial crest transposition as well. And when I do this, I actually make a cut in the tibial crest down here, and I will actually move that whole tibial crest segment and then put it back on with a headless compression screw. I didn't want to do that in this tripod dog because I was worried that with him hopping on 1 leg, there's going to be a huge amount of force placed on this tibial crest. And I was worried that if I had done this repair, that would have had a high chance of failure. And so I went with this option where I've really probably asked a lot of this plate with the way I've bent it. But I think this was, on balance, a safer option to repair this guy. So this modified TPLO, I do this really commonly for little dogs now. So this is my treatment of choice for a small dog. And I'm talking about dogs down as small as kind of 4 or 5 kilos for a combination of a patellar luxation and a tibial crest, patellar luxation and a cruciate rupture. And again, that's the second modification. Again, I guess my comment here is that when you do a TPLO, that's a technically challenging surgery, I believe. Anyway, I've done a lot of those. And with experience, you can get quite proficient, but, you know, there is definitely a learning curve. When you add another level of complexity by cutting off the tibial crest and moving that around, then you've got more pieces of bone, you've got a lot more balls in the air. So you do need to be careful about what you're trying to achieve there and what the risk is going to be. So I'm going to leave the complications section alone there. The final comment I'm going to make just on the combined cruciate rupture and patellar luxation is in those dogs. So I'll go back a couple of slides. In those dogs where we're dealing with a situation where it's an asymptomatic patella and the lameness is just sort of the cruciate rupture, then you can make a case, I believe, for just fixing the cruciate and then ignoring the patella and then coming back and fixing the patella in the future. So if you didn't want to do, in a large breed dog, a TPLO and a tibial crest transposition at the same time, I think it's a reasonable alternative to fix the cruciate, get the dog back to where it was before the cruciate was ruptured, which was an asymptomatic patient, and then decide at that point if we need to do another procedure to fix the patella. So there's nothing wrong necessarily with staging those procedures if we need to. And in terms of risk, in terms of trying to combine the two together versus doing one and then the other one, that might be a safer way to go. The downside is that we're going to have 2 procedures, 2 periods of recovery, 2 expenses, all those kind of things. So I'm going to stop there because I'm waffling on a lot, and I'm going to hand over to Ben. Before I do that, has anyone got any questions? I'll take just a couple of questions before we flip over to Ben. And Ben, what I'm going to do is share my screen with you. If I can work out how to do that. Share screen. I'm going to share with, oops. So, sorry guys. Ben, okay, where are you? Ben, do you want to just, there we go, I found it. So I'm going to make you the host, Ben.
Yep, sounds good.
And then you should be able to change, you should be able to share your screen there. So I'm just going to answer a couple of these questions while you get that set up, Ben. Is there a benefit from doing let me just put the chat section back up. Is there a benefit from doing a wedge versus a block trochleoplasty? Not really, I think it's just personal preference. My personal preference is to do a wedge, but I think Ben does a block, and so it's one of those things that is really personal preference. What about a cranial closing wedge osteotomy in both problems? That certainly is another option. My preference is for a TPLO in general. And so she is giving me some more tips on on Zoom, which I do appreciate. So thank you very much. So I made Ben the host. I think he's away. I'm going to hand over to him. And so thank you very much for all your time, guys. If you have any questions, feel free to reach out to us. And yeah, thanks for listening. How are you, Ben?
Thanks, James. Hey guys, hi chat. Let me know if you have any problems with the videos or if you can't hear me. I'll try and speak slowly and clearly so everyone can hear me, but please feel free to ask questions. Just before I start, I'd love to get just a rough idea from you guys, just how many shunts you guys would see and potentially operate on, for example, in a month. And if you do, would you, what would you use to tie off the shunts, just to get a rough idea as to where everyone's at with that. I can't actually see the chat, so I'll, there we go. I'm just going to move that to the side. Great. Perfect. All right, so bit of a this evening, bit of an overview on hepatic shunts. There are quite a few different types of shunts, but we'll be focusing on congenital portosystemic shunts, and we will look at both cats and dogs, and also intra and extra hepatic shunts. Sorry. So just as an overview, we'll just basically have a brief introduction on liver shunts and what they are, and then how we go about diagnosing them. Dare I say that you guys would be doing a lot more of the diagnosis than someone like myself. And then we'll briefly go over the extrahepatic portosystemic shunt classification. I'm sure some of you have seen the literature. There are quite a few series of papers that make it extremely confusing, and we'll try and decipher some of those different shunts. It may not actually clarify it or make it easier. And then we can also discuss the preoperative management and then the surgical management of both extrahepatic and also intrahepatic, potentially some postoperative complications, outcome. And then I do have some clinical cases at the end as well. So as by way of an introduction, the hepatic blood supply comes from the portal vein and the hepatic artery. In terms of total blood volume, 75% of the liver's blood comes from the portal vein, and 25% comes from the hepatic artery. Basically, the portal vein is an extremely important vessel, and it's one of those vessels that is basically incompatible with life if it is occluded. We'll go over it a little bit further on as well, but just to highlight that in case you aren't familiar with the splanchnic circulation, that is the circulation that is within the GI tract, the liver, and the spleen, and the pancreas. So shunts, excuse me. The two broad sort of types of liver shunts that we'll certainly see in the veterinary practice are congenital shunts, and that's compared to acquired shunts. It's quite interesting in human medicine, very, very rare to see congenital shunts. So it's one area where the veterinary profession is sort of leading the way, whereas it's very common for people to develop acquired shunts due to liver cirrhosis. But congenital shunts, usually they are a single intra or extra hepatic vessel, and it basically diverts, you can sort of see from the picture, it basically diverts blood from the portal vein to the systemic circulation. This picture is showing a portocaval shunt. As I said, majority of them are single. Large breed dogs tend to have intrahepatic shunts. Small breed dogs tend to have extrahepatic shunts, but we've all seen those cases where it is not the case. Generally speaking, intrahepatic shunts are larger, they're a much larger vessel, and hence they shunt more blood away from the liver, bypassing the liver, into systemic circulation. So we tend to see more severe signs much earlier on in life. And there certainly are populations of dogs where you'll see the clinical manifestations of a portosystemic shunt much later on, 7, 8, 9 years of age. In terms of acquired shunts, they tend to be about roughly 20% of all shunts that we see. And mainly they're due to chronic portal hypertension. So that's basically where the blood pressure within the liver is far too high and you just get a backflow of blood into the splanchnic circulation. And that drives the development of acquired shunts. Multiple acquired shunts or acquired shunts, usually they're multiple and they're also extrahepatic. We don't tend to see acquired shunts that are intrahepatic. Excuse me. So in terms of diagnosing a liver shunt, I've kind of divided it into both clinical aspects of diagnosing a shunt compared to the actual diagnostic imaging of assessing a shunt. So clinically, I think this is what the majority of you guys would be seeing. You'll start off with your sigmoid, and with your extrahepatic shunts, you'll typically see toy and small breed dogs, the lovely Yorkshire Terrier in a...
कटिंग कर लो कटिंग इसकी वो आएंगे फिर.
Oops, sorry, I'll just try and mute everyone.
हाँ?
So Ben, if you just go to participants, you should be able to just select mute all.
Where do you find that, James?
If you go up into the top section, I believe there should be a drop-down menu.
Ben, you'll see in the participants list. If you click on participants, you can then mute from there.
Take support. I'll come and have a look, Ben.
I'm also a novice with Zoom.
Okay, do you see participants at the bottom of your screen? Okay, you've got the control bar on the top, right, sir?
Got it. Thank you. Sorry to cut you off. Perfect, sorry about that. So with the intrahepatic shunts, tend to be, as I said, large breed dogs, and the Irish Wolfhound and the Labrador Retrievers tend to be overrepresented. And then with cats, there's limited information on cats, but they tend to be the Oriental breeds, the Persians, Siamese, Burmese, and they tend to have extrahepatic shunts as well. In terms of the history and the onset of clinical signs, I mean, the classic thing that you'll see in the history is failure to thrive. It's the runt of the litter, poor body condition score. That tends to be for dogs, and we will go into cats and how they vary slightly as well. If it's a single congenital shunt, clinical signs tend to obviously be a little bit sooner, as early as 1 month to a couple of years old. If they're multiple acquired and it's due to chronic hepatic disease, sometimes you might not see those signs until much later on in life. In terms of the other clinical signs that we'll see, broadly speaking, we'll see neurological problems, gastrointestinal problems, urinary signs, and also some sort of overall coagulopathic disorders. In one paper, about 70% of dogs would show some form of neurological sign, whether it's mild lethargy, ataxia, pacing, blindness, and they can escalate very quickly to uncontrollable seizures. About 50% of these will correlate directly with a meal, as in they will have a meal and then they'll show signs afterwards. And then after that, they will improve. And the neurological signs can be related to hepatic encephalopathy, hyperammonemia. There are lots of different hypotheses as to why we see these neurological signs, but certainly the increased ammonia and the HE are very common. In about 30% of dogs, we'll see gastrointestinal signs, and that's where you'll have the mild vomiting, diarrhea, anorexia, hyporexia. Quite a few cases will have gastrointestinal bleeding, so you may see changes with their feces. And interestingly, in cats, a lot of cats will actually have tylism or hypersalivation as a very common gastrointestinal sign. And due to the liver dysfunction and also the gastrointestinal disease, as we mentioned before, they'll be in poor body condition and small. Due to the ammonium urate calculi and the formation of stones, these guys can also develop signs of cysts. We were just making sure that this was recorded for everyone. Hope that's okay, Charles.
Yeah, great, thanks.
Great, sorry guys. And then in terms of the shunt abnormalities that we'll see on sort of blood work, urinalysis, I mean, this is the sort of bread and butter for you guys where, run hematology, biochemistry, and you'll see a lot of these changes. I'm sure everyone's aware, but it's really important to understand the difference between liver dysfunction, so where the actual function of the liver is abnormal, so that's where we see the hypoalbuminemia, the abnormal cholesterol, altered glucose, as opposed to the ALT and ALP phos, which may indicate actual damage or trauma to the hepatocytes. Often you'll see a low USG, and that's usually because of the low urea production and low renal concentrating ability, because there's a lack of urea there, or potentially hepatic encephalopathy causing polydipsia. And as mentioned before, you'll also see the ammonium biurate crystalluria or even proteinuria. And in some cases, you will see depletion of the coagulation factors, and you may actually have a coagulopathic patient. In terms of liver function, the most common test that we would routinely perform is a bile acid test. I won't go into that because I'm sure everyone's very well aware of that. A less common one that is reported, but to be honest, I've never actually seen, is the ammonia tolerance test. And that actually can be quite sort of sensitive, but it's not overly specific for a liver shunt, nor is a bile acid test. It just shows the liver function. Now, in terms of diagnostic imaging, so I hope everyone can see this table, but there are lots of different ways where you can more definitively diagnose a portosystemic shunt. The most common ones that we would use are ultrasound, CTA, which is computed tomographic angiography, and IOMP, which is the intra-operative mesenteric portovenography. The advantage of the ultrasound is that it can be performed non-invasively. It can be performed under sedation or consciously. It's readily available and relatively cheap. In my experience, it really is operator dependent. And also, if you're the surgeon performing the surgery and you would like to know the sort of anatomy of the shunt, it's difficult if you're not the person holding the probe, and I'm certainly not skilled enough to be able to get anywhere near close enough to finding a portosystemic shunt on ultrasound. Normally here we would perform CT angiography and on occasions the intraoperative mesenteric portovenography. We've got quite a few cases of those, and I can show you those for those who are unfamiliar with it. Oh no, I did the red line as well. Now, this is where we get into the classification systems of the extrahepatic portosystemic shunts. There are two broad classifications. The first one, which was in 2011, was by Nelson and Nelson. And these two really tried to emphasize a classification system whereby there was an origin and insertion. So you're really describing where the shunt originated from, which vessel, and where it inserted onto. And these guys looked through a whole list of shunts, and they came up with 6 general types of portosystemic shunts, and they're listed down here. Hopefully these diagrams make it a little bit easier to try and visualize what exactly is going on. So the most common shunt morphology, and just remember these are all in dogs, are splenocaval shunts. So this is where it goes from the splenic vein into the cava. The next shunt that was that they described was the splenophrenic. So that's a shunting vessel from the splenic vein to the left phrenic vein. So that's a shunt that you would access sort of between the liver and the diaphragm, and some papers actually report a incision into the diaphragm, into the chest cavity to access that. And then also the next one is a splenoazygous shunt. So that's where there's a shunting vessel from the splenic vein to the actual azygous vein. And then a, whoops, sorry. Oh, I seem to have missed one, but there's the double right gastric azygous, and then a right gastric caval, which is one that really does a nice little loop to loop. And then a double right gastric caval shunt as well. And you can imagine that just, you know, if you're looking at ultrasound, how tricky it can be to try and visualize all of these. And that's why my preference is a CT or intraoperative portovenography. The next 2 people that came along were Rob White and Andrew Parry, and these guys are in the UK. And through the space of about 5 years, they released these extremely detailed papers in the JSAP journal, basically trying to reclassify the different types of shunts that we've seen. And I'll try and go through some of these as well. So first of all, they looked at shunts that arose from the left gastric vein, and from the left gastric vein, there were 3. There was basically a gastrophrenic, gastroazygous, a gastrocaval. And some of these, to make it even more confusing, overlapped with the previous Nelson paper. The most common one were the splenocaval, and thankfully they agreed that that would be the same nomenclature as the Nelson paper, and that is the most common. And then they sort of described 2 more, which were the right shunts that originated from the right gastric vein. And then I'm not going to go into detail, as I'll probably embarrass myself because I barely understand it, but they had various types, A1, A2, A3, and type B. And then this little picture down here describes the left colic vein. Excuse me. So the problem that we have now is we've got these very well described and widely accepted forms of classification systems for extrahepatic portosystemic shunts. But the big question is, you know, which system is best? To be honest, I don't think we have a preference. There's no agreement in sort of the veterinary world. But the biggest question that has arisen is, it's fantastic to classify these shunts in all the different ways. However, you know, does it really matter? Is it just an academic classification system for veterinary radiologists? And from a surgical perspective, you know, we're surgeons. The point of insertion on the caudal vena cava is far more important then what type of what type of shunt classification it is. And this was followed up actually by the White and Parry guys, and they were looking at the implications of shunt morphology for the surgical management. And they basically decided that with all of the 15 different types of classification systems, ultimately they inserted at 4 consistent sites. The first one is in the prehepatic caudal vena cava at the level of the epiploic foramen. So it's basically outlined, I know it's not the accurate representation, but it's sort of at around this level here, demarcated with the red star. And to be honest, that's where the majority of extrahepatic shunts that I've operated on insert into. And then they'll also insert into the left phrenic vein at the level of the esophageal hiatus, which is sort of around here. And then the esophagus vein at the level of the aortic hiatus. And then with those left colic shunts, they'll insert at the cava at the level of about the 6th or 7th lumbar vertebrae. So I find if you're performing, if you are confident that there is a shunt, and you just want to have a look at the insertions points, these are the 4 sites that when you're doing your exploratory laparotomy, that you'll have a really good idea as to whether they insert at this level. So now in terms of preoperative medical management, this is really, really important. And the attenuation of a liver shunt is basically it's never an emergency. Sorry guys, seconds. When you have a patient that has a shunt, they'll often have a significant morbidity. They're neurologically abnormal, they're in poor body condition, they can barely control their glucose, sometimes they're coagulopathic, and they are, in general, they don't tolerate anesthesia very well, they barely tolerate, drugs overly well. So it's generally in your best interest to try and manage these medically before taking them to surgery. Oh, definitely wasn't me, that little yellow light. In one paper, body condition is an indicator of liver function. When the paper looked at intra-operative portosystemic shunts, those that were greater than 10 kilograms had a much better outcome. And then finally, with treatment, generally the recommendation is to treat them at least 2 weeks prior to surgery. And how we would do that is by changing their diet. So placing them on a moderate protein restriction, a really readily digestible diet with, a liver diet, Purina HA. One of the big things that I find helps is giving them lactulose. And often we would just give that orally, but if they're really affected, you can give them a lactulose enema as well. And the lactulose works in 2 ways. It converts ammonia to ammonium, and that way the ammonium can't actually cross over into the blood supply from the colon, and hence your hyperammonemia won't be as bad. And then the lactulose also acts as a cathartic. It increases fecal transit time. So, all of those, proteins can't be as absorbed as quickly. You can also, as I mentioned before, if they're showing neurological signs, perform an enema. And then the last 2 points, the antibiotics and the levetiracetam, or levetiracetam, they are commonly implemented, or they have been commonly implemented. We'll go into the paper a little bit later, but some recent literature shows that the placing them on the antibiotics or the levetiracetam doesn't affect the likelihood of developing neurological signs afterwards. And for those that don't know, levetiracetam or Keppra, it's an anti-seizure medication. So in terms of surgical management, particularly of extrahepatic shunts, I mean, it sounds obvious, but the aim is to identify the shunting vessel, to attenuate it, and to redirect blood flow to the liver. You want to basically put blood back into the liver to restore a normal hepatic function, but I guess, do we actually get to normal, in inverted commas? Not quite sure, and there is another paper that we'll discuss later on. But by far and large, the surgical correction of a shunt, or even partially attenuating a liver shunt, is much better than long-term medical management. The medical management tends to address the clinical signs, but surgical attenuation, redirecting blood into the liver, actually increases the blood flow and the hepatic development, hence liver function. Generally speaking, when you try and attempt to attenuate an extrahepatic shunt, about 50% of them you can completely sort of ligate or attenuate. About 50% of them have a liver that has developed a robust enough capacity to actually tolerate all of a sudden all of the blood that goes through the shunting vessel back into the liver. Because the risk is, if that the liver is completely underdeveloped and you basically put a roadblock up on the shunt, you'll direct all of that blood into the liver cannot cope, and you'll develop portal hypertension. The common ways that we would attenuate or address a shunting vessel would be with suture. So commonly I'd use proline suture. And with the suture, you can either completely attenuate it, or you can tie it off such that you give it a little bit of a waste. You only partially occlude it. This structure here, in case people haven't seen it, is what we call an amyloid constrictor, and the blue component is, I think it's casein, which is essentially a cheese, and that is supposed to promote just a reaction, inflammation, and over time the body will self attenuate it. Similarly with cellophane, that cellophane aims to cause a sterile inflammation around the shunting vessel, and then as you develop that scar tissue, that will gradually shut down the vessel, will gradually occlude it, and with time the liver will hopefully cope with that increased blood supply. The difficulty with the cellophane and the amyloid constrictors is that it's difficult to predict the rate at which that shunt may close, and it's difficult without checking again to know whether it actually closes completely. There are reports of people using hydraulic occluders. So that's the hydraulic occluders, you might be familiar with them. People will use them in USMI cases. And it's where you've got a subcutaneous port and you can inject a little bit of fluid. I don't have any experience with these with shunts, and I'd recommend either suture constrictors or cellophane band. And then the aim is to always attenuate at the point of insertion. Just in case you have a double shunt that you haven't recognized, if you attenuate it at its origin as opposed to the caval insertion, there's a risk that you may miss something. And then with intrahepatic shunts, these cases are much more challenging. They are much larger vessels, really large vessels, and they're hidden within the liver parenchyma, and they're often thin-walled. And with these cases, if you have a bleed, they can be fatal. There is quite a few, and we do it here at Southpaws, there are quite a few places that will do a transcutaneous approach or a transvenous coil embolization. And that is where, sorry, just on this right, this is a CT angiogram of a shunt. And you can just see, this is the large shunting vessel that's coming through there. And so it's, this is the portal vein coming up, and then it comes up and then loops around and then inserts into the cave. I'll just go back again so you guys can see that. But the transvenous coil embolization, access is obtained via the jugular. And then basically, you would put in a coil, and there are various different types of coil as to whether you want to completely or gradually attenuate the shunt. And then these coils are held in place with a stent that's actually in the jugular. Advantage of this is that it really is minimally invasive, and you do have excellent outcomes with these. In this particular paper at 3 months, the actual blood work, so the biochemistry and the hematology, it improved by at least 50%, so for the spelling mistake, and almost 100% of the dogs were. Oh, sorry guys. Oh.
नहीं अभी तो ऐसे चलो कोई ऐसा है नहीं बाकी एक तो पीस आपका डिफेक्टिव आया तो बड़ा बना था
Yeah, I did. Did you know to remove these lines? Oh, nice. I think that's actually one here as well. Thanks, Joe. I don't know how you're on it. Well. Perfect. So in terms of the procedure, as some of you guys haven't, sorry, this is one more annoying red line. Oh, brilliant. Some of you haven't sort of attempted a extrahepatic shunt or an intrahepatic shunt. Basically, it's a midline ciliotomy, and it's really important to, do a large, xiphoid to pubis almost laparotomy. And then you want to explore those 4 places to make sure that there aren't any other shunts there that you potentially may have missed. You want to identify the shunting vessel and find a good access point, because you will, when you want to dissect around it, you do need to use right-angled forceps and really dissect it around it. So often, you might go through the omental bursa, you might pull the duodenum across, you might pull the colon across. It's important just to visualize the shunt in various aspects to see which is the best place to dissect around it, and also that there'll be enough room to pass suture or place an amyloid constrictor or to pass cellophane around it. The next step I'd usually perform is the intraoperative mesenteric portovenography, and the next slide will go into sort of how we do that. And then we would place a Rummel tourniquet. A Rummel tourniquet looks like a plastic straw, and it essentially allows you to temporarily completely occlude the shunting vessel. So you're able to temporarily test what it would be like if you completely attenuated the vessel and see what will happen to the animal. And then whether it's complete or partial, you may elect to completely tie it off with your proline, or partially, if you prefer to partially attenuate it, then you could then place your cellophane, or only half tie it down with the proline, or place your amyloid. So the big question is that what can an animal tolerate? And what we would do is place a cannula into one of the jejunal or mesenteric veins, and then we would connect it to a transducer, to basically one of the blood pressure monitoring on the anesthetic machine, and then we're able to assess, not systemic blood pressure, but portal pressures. And the portal pressure is basically what is going on, around here. And it should be, it's venous, and it should be very low. It's not your arterial pressure. It should be very low. Just to highlight again, this is an example of the splanchnic system. So you've got arterial blood coming to the GI, spleen, pancreas tract. And then all of these vessels basically form tributaries into the portal vein. And then it's this one portal vein that then goes into the liver. And if we have a shunting vessel that comes across, and we suddenly tie that off, you can see how the poor liver can be very much overloaded with blood. You can develop portal hypertension, and then that can lead to a backflow of blood to the GI tract, backflow of blood to the spleen and the pancreas. And touch wood, haven't seen it, but portal hypertension, it can be fatal. The caveat to that is that to attenuate a shunt, when you attenuate a shunt, you do have to create a degree of portal hypertension to force the blood into the liver. So it's just sort of that grey area as to what is acceptable portal hypertension and what is unacceptable. And there are some guidelines, and these are for extrahepatic shunts that I know. There are some guidelines for intrahepatic shunts as well. But generally speaking, you don't want to increase the portal pressures more than 10 centimetres of water. And just note the difference in units, centimetres of water versus millimetres of mercury. You don't want to double the initial portal pressures. So if your portal pressure is 10, you don't want to go above 20. If it's 8, you don't want to go above 16. But just in general, you don't want to go above 18 to 22. And when you use that Rommel tourniquet to temporarily occlude the shunting vessel, you can assess these basically real time to see what happens. More of a subjective method is that if you are going to get a large proportion of backflow into the splanchnic system, you can actually look at what the pancreas and the GI tract does. And it's actually quite remarkable. It happens very quickly. And the person who's doing the anesthesia starts to get a little bit twitchy. Basically, you'll have pooling of the blood within the splanchnic system. The GI tract all of a sudden becomes really quite congested and dark, and it just looks angry. It's hypermotile, and if you get to that stage, the animal can't tolerate it. And also a good one to look at is the pancreas. Instead of that lovely salmon pink color, it becomes a really dark, it almost looks like coffee ground appearance to it. And then it's also a good idea, if possible, to assess what's happening systemically. So all of a sudden you'll have pooling of blood within the splanchnic system. So it is not in, in the where you would normally be measuring a blood pressure. So you are clinically going to see a hypotensive patient with a tachycardia as well. So in terms of the intraoperative mesenteric portovenography, excuse me, just a simple IV catheter can be placed just into a nice little straight, usually it's a jejunal vein, and then it's temporarily just sutured to the gut, and then you can link that to an anesthetic machine. And the advantage is that you're able to measure portal pressures, but also do the portovenography. So that's where, roughly 1 ml per kilo, and you can dilute it 50-50 with normal saline. You can inject contrast into the mesenteric vessel, and then it funnels its way all the way to the portal vein, and then you can actually then diagnose the shunt, and you can, you know, assess real time what you're doing to that shunt. Some of the advantages are that you're able to, you know, achieve a definitive diagnosis. You can assess both types in terms of intra and extra hepatic shunts. Often, depending on how much pressure you apply when you're injecting the contrast, you can also rule out secondary shunts. And you can also, once you've dissected around the vessel, the shunting vessel, and you put your rumble tourniquet on, you can confirm that that is the shunting vessel. I have on one occasion dissected accidentally around the renal vein, and then when I placed and then did the portovenography, you know, you could still see the shunting vessel. We hadn't made a difference. And then what actually is quite nice is you can assess hepatic arborization. Arborization meaning sort of, it kind of looks like a tree, and if you have a lot of arborization in the liver, that generally means that your liver has got a good vascular system, so probably would be able to tolerate more blood going through it. So potentially you'd be able to completely attenuate it. Now, in terms of post-operative complications, one of the big ones that we do see is the post-ligation neurological syndrome, or post-attenuation neurological syndrome, or PANS. Probably about 10% of these will develop when you include the shunt. Will develop, and it doesn't have to be complete attenuation. It can be partial attenuation, just by altering the amount of blood that goes into the liver, and hence you're increasing liver function, and that alters all of the, you know, the ammonia and the just general metabolism. That can then, we theorize, can alter what happens at the neurological level, and then that's why we would often see this post-ligation neurological syndrome. 1 to 2% of these cases, it's really severe, and they're not responsive to medication, and, you know, they can seizure uncontrollably, and often, you know, in these particular subset of cases, you know, it can be fatal. Often we'll see it at about 3 to 5 days post-surgery, and won't go into it mainly because there are just so many theories, but there are lots of different reasons as to why it would happen. Second complication is, obviously you can have hemorrhage, and then you can also develop post-operative hypoglycemia. Sorry, one sec. And then you do have about a 5% risk that you'll develop a multiple acquired shunt. So that probably means that you've tried to push the system a little bit too much. You've tried to divert too much blood to the liver, develops portal hypertension, and then the body's defense mechanism against portal hypertension is to create alternate avenues back to the cava or back to the system, and that's where we get multiple acquired shunts, and that's quite a frustrating condition to deal with. Theoretically, you can have recanalization of a shunting vessel as well, and it is a bit debated, but a lot of people will think that intrahepatic shunts, they're less likely to show this post-attenuation neurological syndrome. Rhiannon's paper here, which was a couple of years ago in VetSurg, they didn't see a difference between intra or extra hepatic shunts. So in terms of outcome, as I said before, about 50% can be fully ligated, 50% require partial ligation. Usually you would check whether what's going on. You know, often we would repeat ultrasound or repeat CT angiography. And I guess that is the difference between the cellophane and the amyloid constrictor. Theoretically, that is a one-shot surgery. So you would go in, identify the shunting vessel, place the cellophane band, place the amyloid constrictor. Then you would expect that over time, 3 months, 6 months, a year, that shunting vessel will then be occluded. As opposed to what I'd say a definitive surgery. So what we have done on occasions is that if an animal cannot tolerate a complete attenuation, we would place a proline suture, give the shunt a bit of a waistline, and then come back in 3 to 6 months' time, and then do a definitive closure. Usually, probably 95% of cases would only require 2 surgeries. In terms of the literature out there, mortality rates, they really do vary. With a suture, somewhere between 2 to 30%. Maybe it's just because I'm lucky, but definitely much closer to the 2 than the 30%. In a recent paper, the amyloid constrictor seemed to be superior compared to the other methods. So there is a slight trend for clinicians to use an amyloid constrictor. And just in general, there seems to be just a high mortality rate with intra-operative, but that varies whether you're attempting an open approach or like a coil approach, a minimally invasive approach. Generally speaking, we see really good to excellent long-term outcome. However, the double-blind or prospective studies, they are lacking. And it's also quite difficult to say, well, excellent outcome, is that from a biochemical perspective, or is that from a body condition perspective? Is that from a clinical sign, or is that just a owner feels that the dog or cat's doing a lot better? Excuse me. One interesting paper from JSAP, I think it was a couple of years ago now, written by Poppy, that showed that they looked at bile acid concentrations in the short term and also the long term after they had had either complete extrahepatic shunt ligation and in dogs. And interestingly, in the short term, after a couple of months, the bile acids, this is pre-prandial, were about 49, and then post-prandial, they went up to 90. And then in the long run, they had a pre-prandial bile acids of about 90, let's say, and that went up to about 120 or so. But there are inherent flaws in a retrospective study, but I guess the take-home message is that even after complete attenuation, and animals are doing absolutely fantastic, they may still have slightly abnormal bile acids. Roughly, it's a very, very arbitrary number, but if you start to have clinical signs and your bile acids are greater than, sorry about the units, greater than 100, then you might consider that you have got multiple acquired shunts. So there was just one question: are there any advantages of the suture for someone to choose it over an amyloid when mortality may be up to 30%? Is the cost very different? Truth be told, I don't know how much an amyloid constrictor is, but it would definitely be more. We're literally using like 2,0 proline, so that would be much cheaper and much more cost effective. But I guess the thing that you would have to weigh up is that if you have a shunt that you cannot completely attenuate, if you place the amyloid constrictor on, you would potentially only have one surgery. Whereas if you elected to partially attenuate with suture, and then in 6 months' time perform a second definitive surgery, then you would have to weigh up the cost of 2 surgeries. And I think that varies from surgeon to surgeon, from country to country, and hospital to hospital. And then we do talk about it a little bit later as well, but in cats, a lot of the time they'll develop neurological signs afterwards, and they'll have, you know, transient central blindness. You know, day 3 after a shunt that's gone really, really well, they'll suddenly go blind, and usually it comes back after, you know, 5, 6, 7 days. And another thing that we will see in cats as well is, you know, about 30% will have seizures. But with the cats, you would still expect, you know, a very good outcome. So this was a abstract that was presented recently at BSAVA, and it was actually looking at hepatic shunts in cats. Excuse me, and this was from a UK centre at the Royal Veterinary College. About 60% of the cats that had either partial or full attenuation, 60%, which is, you know, 2/3, developed post-attenuation neurological syndrome. They looked at a lot of different factors, and there was a trend that the cats that had a lower blood osmolarity tended to have the neurological signs, or those that had the PANS had the lower blood osmolarity. I think it's more of a academic fun fact than it being sort of clinically helpful. About 5% of the 60% of cats, they died basically due to neurological deterioration. What they also found was that the perioperative use of levetiracetam was not protective against either seizures or PANS. And in this paper, or soon-to-be paper, the PANS was not associated with preoperative hepatic encephalopathy. The age of the cat, you know, was it a young kitten or an old cat? The shunt morphology, whether it was intra or extrahepatic, or the degree of attenuation, whether it was partially or complete. So I guess cats are cats. So how are we going for time? Not too bad. We'll just go through 3 cases, and probably be only another 10, 15 minutes or so. And we'll briefly go through sort of the interesting points of the case. And I think for each of them, we've got just examples of intraoperative portophenography. Case 1 is an animal called Kate. Case 2 is an animal called Charles, and case 3 is an animal called James. There was just a question about, please explain the mechanism behind PANS. I'd honestly love to, but in all honesty, I don't think anybody really knows. I mean, theorizing it, the brain gets used to a certain level of, in inverted commas, blood abnormalities due to the underdeveloped liver. And, you know, through the entire animal's life, that is normal for the brain. As you start to try and push blood into the liver, you increase liver function, and the liver starts to do its job. And then all of these biochemical, you know, ammonia, all of these abnormalities that we perceive as abnormalities, they suddenly improve. And it's theorized that this may then affect the brain, because suddenly the brain isn't used to it. It's sort of like withdrawals in a way. That's an extremely simplified version, and that's basically at my knowledge level. But there's certainly a lot of interest into exactly what is going on, because in all honesty, we really don't know. So Kate is a 6-month-old female entire cabochon. This is her CT angiogram. Hopefully I've made it so it'll just keep playing through. So I'll let you guys see if you can identify the shunting vessel. It had the, the classic hematology, biochemistry, and liver, functions. The preprandial bile acids were very, very high, 100 and 140. Apologies, I don't know what it was post. And Kate was in a very poor body condition. With this CT angiography, you can see a single extrahepatic portosystemic shunt. For those with a keen eye, you can see a gastric foreign body, which is a button. That was an incidental finding. And then you can start to see the shunting vessel here. We are sort of working backwards, so that's the cava. And then if you follow this portion here, you can see it trace back to the portal vein. So this is the start of the portal vein. And if I just go back again, I actually find it's easy going from caudal to cranial, but I didn't know how to flip the video. So you can sort of see that U-shaped vessel. So that's a classic splenocaval shunt. And, that's one of the most common that we'll see in both the dog and cat. Excuse me. So this is intra-operative. And this is using fluoroscopy. And the reason why you only see a faint outline is that we've performed subtraction. So basically, the system has kind of whited out everything. So when we inject contrast, you can see a lovely black squiggly line. This, for interest's sake, that's the button in the stomach. And then this sort of long straw-like structure, that is the Rummel tourniquet. So the shunting vessel is around here. You have a suture that goes down the Rummel tourniquet, around the vessel, and then back up. And then by moving the actual plastic Rummel tourniquet, you can temporarily occlude the vessel. So this is a portophenography of pre-attenuation or pre-ligation. I can just get to play. So you can see contrast being injected up through the mesenteric vessel, and then you can see it shunting around. Play that again. You can see it shunting around, and then you'll see it just go straight up into the vena cava and into the heart. What you should see is if you inject contrast into the mesenteric vessel, you should see it actually highlight the liver. You should be able to see arborization. So this is what we've performed here. We've now temporarily fully occluded the shunt with the Rummel tourniquet. So you can see that coming down here. Let me just move the participants. And then if we play, you can see contrast goes in, it hits the Rummel tourniquet, and then you get arborization of the liver. You can actually see contrast going into the liver as it should. And then after that, you see the blood or the contrast then go into the cava. So that's the correct flow of blood. So Kate fortunately was able to have complete attenuation of the vessel and then did exceptionally well afterwards. The next case is Charles, and Charles is a 1-year-old cavapoo, and Charles actually presented with acute urethral obstruction, and then through stabilization of the urethral obstruction, biochemically had a blood panel that was very suggestive of a shunt. And then this is what we call a retrograde urethrocystogram. So that's where contrast is injected through the penile urethra all the way into the bladder, and you can actually see the offending stone just in here. So this mainly highlights the different ways in which shunts can present. We then did CT angiography, and this particular guy had a intra-hepatic shunt, what we call a right divisional, so it was on the right side of the liver. So again, this was the shunting, the intraoperative portovenography. And you can actually see the catheter heading into the mesenteric vessel, up the portal vein, and then to the right side of the liver. This is always the right, and that's the left. It does a bit of a loop-the-loop, and then goes straight into the cava. And you can see that, I mean, this is blood that's taken from the gastrointestinal tract, and it should be basically assessed or seen by the liver, and it should really highlight the whole liver. But we're not seeing anything. There's a huge portion of blood that is just going straight into this shunt and then straight into the cava. And then this is the this is an open approach. So again, this is after dissecting around the shunt, and there is temporary occlusion of that vessel. So you can see contrast going into the portal vein. It builds up in the shunting vessel, but this is the level of the tourniquet. And then you see this wonderful arborization of the liver. So this is the liver that basically was being starved of blood because of this shunt. Just play that once more. And then this is sort of backflow here. I think Charles had a temporary suture placed around that he didn't tolerate full attenuation. And then the last case, James, was a slightly temperamental ragdoll cat that presented, not unexpected, with primary neurological abnormalities, ataxia, intermittent seizures, and I think also had some poor body condition, was medically managed with a liver diet and lactulose and responded really, really well. And then he, through abdominal ultrasonography, had a single extrahepatic shunt. Excuse me. So this was the first surgery, pre-attenuation, and this is actually a really nice portovenogram. You can see the contrast. It's literally like a highway that just goes straight from the gastrointestinal tract all the way up to the heart. And you can basically see no blood, no contrast going into the liver. This is the portovenography after full attenuation with the Rommel tourniquet. And you can, let me just play that again. And you can see that's basically where the shunt is. And then this is the portal vein going into the liver. And then you start to see arborization. This guy didn't tolerate complete attenuation. So we actually placed a cellophane band. And you can see the cellophane band. It's literally a little bit of cellophane. And then you can actually see the hemoclip or the liber clip. So it's a little staple that sort of you wrap it around it. And you can actually see quite nicely that we've created just a little bit of a waistline to that vessel. And even though you can't see it, we're sort of forcing blood away from the shunt into the liver. We then got James back about 6 months later because he was still showing some abnormal signs. And then at surgery, when we performed the portovenography, we found that we had all of these little squiggly vessels develop. So you can see here going up, and then we develop all of these squiggly vessels. And then before the blood reaches the cava and the heart, it went into the esophagus. So unfortunately, this guy had developed multiple acquired shunts, which was a bit of a sad case. They're literally, 10, 20, 30, 40, hundreds of these little vessels. And basically, you can't address them surgically. You have to address them medically from then on. Karen's asking, could you put a ligature on the insertion and the origin site. Yeah, I think you probably could. You probably wouldn't need to, just because it's quite it's quite hairy, just dissecting around a shunt. So having to do it twice, I'm not sure if I could cope with that. But you could generally do. Generally, we'd recommend just putting a ligature on the insertion as opposed to the origin. So summarising, I guess portosystemic shunts, they do have significant morbidity, and primarily due to liver dysfunction. Medical management helps to ameliorate clinical signs, but it's the surgical attenuation, whether that's open or minimally invasively, that improves the hepatic blood supply, and that's really what you're after. And broadly speaking, we tend to get very good to excellent long-term outcomes for both extrahepatic and intrahepatic shunts. Just a couple of acknowledgements, Charles and James, who I work with, and then also Rhiannon and Mark, who I worked with my time in the UK. And then any questions, be happy to answer them. I didn't know, James, if you wanted to say anything or wrap things up, or Charles.
Yeah, no, that's great, Ben. Excellent presentation. Really enjoyed that. Love the border venograms. Are fantastic videos to look at. So just wait a couple of moments for any questions for Ben to come through. Just while we're doing that, just want to thank you all again for taking the time out of your day and evening, depending on where you are, to see the webinar that we put on for you guys. Hopefully it was of use. And we have recorded these videos, so we'll send a link to the video hopefully tomorrow to everyone that was registered. So really hope you enjoyed everything that you've seen there. Again, if you are more interested in what we've got going on and want to get a bit deeper into the patellar luxation discussion, then you can certainly get onto VetDojo.com, have a look at the module there, have a look at the other modules. If you have any questions for us, then certainly let us know. And yeah, really enjoyed that, Ben. It was great. So I hope you guys enjoyed it as much as I did. And yeah, we'll see you all soon.
I have a question.
Oh, yeah, far away.
So when diagnosing shunts, do you usually go like blood tests, survey rads, and abdominal ultrasound and CT, and by then something shows up? Is that right? Because otherwise the other thing that you did, like the IOMP, is like intra-op already, right?
Yes, exactly right. Normally we would perform basically a complete workup for a pretty non-specific clinical sign, which is vomiting and diarrhea. So they would routinely have hematology and biochemistry, and urine analysis, and if you're lucky you might see some ammonium urate crystals, so crystal urea, and then from that I think most people would have an inclination as to, maybe this is a shunt, maybe it's a shunting vessel. Then the next step to assess liver function, we normally perform a bile acid stimulation test, and then potentially, from there do a minimally invasive diagnostic imaging, whether that's a CT or ultrasound. And then a lot of that intraoperative portovenography is more to like real time, just make sure that you have gone around the shunt and potentially see multiple shunts. It's just sometimes on ultrasound it's easy to find the first shunt, but then it's quite difficult to see the second one.
Okay, thanks.
Okay, if there's no more questions, we might wrap it up there. And again, thank you guys very much. Thank you, Ben, for putting that on for us tonight.
Oh, thank you, guys. It was a pleasure, and hopefully we'll see you guys next time.
Okay, perfect. All right, we'll wrap it up there. Thanks, guys.